Welcome
Mr. Chairman,
to,
you are live.
thank you. Welcome to the third edition of the Subcommittee on the Wyoming Department of Health's budget. Um, I would ask, first of all, that we have the roll taken. So whoever on LSO has that task, please do so.
Mr. Chairman, this is for the Wyoming Department of Health Subcommittee. It is October 28th. Senator Larson,
Here.
Representative Sherwood,
Here.
Chairman Pendergraph.
Here.
Mr. Chairman, you have a quorum.
Thank you. As is our custom, we'll begin with the brief prayer, if you would, please. Lord, thank you for this day. Thank you for the opportunity to serve the people of this great state. We ask that we would be able to do so with wisdom and grace. And we ask your blessing on this meeting. Amen. All right. Change things up just slightly and ask the good senator and Representative Sherwood if you have any opening remarks. Senator?
Mr. Chairman, I don't. Ready to learn some more. There's so much here. Thank you.
Absolutely. It's kind of daunting. Representative Sherwood.
Just additional, thanks and grace for the staff who have provided this opportunity for us to learn. The more we know, the better we can do at our jobs and serving our constituents. So thank you. Thank you for your time.
And thank you both for serving on this committee. I know it's a big chunk in your spare time. I want to take just a second and remind everybody while we're here. Back in January of last year, we got some long-term revenue expenditure forecasts from LSO, and they painted a rather disappointing picture that, depending on what happens with various circumstances, it might put us about $500 million in the hole within a couple of years. And so being aware of that, and then also at an appropriations meeting, we discussed the DD waiver program and the lack of funding for that. And so part of what we're trying to do is see if maybe some funding could be shifted over to that area. Those are all things that we're working on, that we're trying to put together. So I've stated several times before, and yet there are those out there who would claim that I'm, coming at this with a chainsaw and an axe. That is not our intent. Our intent is to, if cuts are necessary, to make them as judiciously and as carefully as possible so that as few people are affected as possible. But there may well be a need to do that. And so we've taken this opportunity to learn as much as we possibly can so that we can do it well. And we ask your patience in that. First topic is workforce review. And I would state at the onset, this committee is acutely aware of a number of the issues that not only affect the Department of Health, but most of the agencies around the state. And that is very difficult to keep and hold help when you're limited on what you can pay and some of those liberties. So yes, you need the opportunity to state those facts for us and to put those out there. My point, though, is I don't want to belabor this section too long. If there are other ideas, please bring those up, make us aware of whatever we need to be aware of. But I'm really interested in spending some time in the health stat. I found that document to be particularly helpful, and it raised a lot of questions. As I mentioned earlier, I'll bring some of those up today, and some of those we'll hold for a later time. So without any further delay, Director Johansson, if you would lead us into the workforce review.
Well, thank you, Mr. Chairman and members of the committee. Stephen Johansson with the Wyoming Department of Health. Good to be with you again. Really honored and pleased. I know you sent an invite, and She's joining us today, our Director of the Department of Administration and Information, Tricia Bach, and the Human Resources Division Administrator, Aaron Williams, are online as well. That's an agency that we, as the Department of Health, obviously, with the kind of staffing we have, we work very closely with, hand in hand with, and receive a lot of support from them. And I think you'll find in my brief overview, as well as comments that they make, they'll be acutely aware of the challenges that we face in the Department of Health with some of our recruitment and retention. One of those areas we'll talk about today with our direct care staffing. But Mr. Chairman, as you mentioned, acute pockets all over the state government enterprise where this is also a challenge. So we're certainly not a special snowflake in that regard, but in the spirit of being brief and your direction not to belabor some of the points that we've already discussed with this subcommittee, with the Labor Health Committee, with the Judiciary Committee, I think we've hit a lot of the high points on what happens when we have those vacancy rates at the state hospital, at the Life Resource Center, at the retirement center. So my overview will be very brief, Mr. Chairman. We also sent what we hope is a short and sweet 3-page document to you that kind of outlines the direct care facility vacancies a little bit more granularly, provides a few charts, some of which are just a review of data you've already seen, but also some projections and modeling of where we compare to Bureau of Labor Statistics averages and things like that. But again, in the spirit of brevity, just a few highlights that I'd like to make when it comes to our direct care vacancy and recruiting challenges in the Department of Health. First of all, the who are we talking about? And with this subcommittee, we've gone over the agency overview, and when it comes to this issue of staffing, recruitment, wages, et cetera, we're primarily talking about our 5 24/7 direct care safety net facilities. So the State Hospital in Evanston, the Wyoming Life Resource Center in Lander, Retirement Center in Basin, the Pioneer Home in Thermopolis, and the Veterans Home in Buffalo. But also where we recruit and have direct care staff are also primarily in nursing at all of our state public health offices, which exist in every county of the state. And the majority of those are state run. There are a handful who have elected to go either in a hybrid or an independent model where they essentially use county employees to staff those offices. But the majority of those public health nursing offices that provide long-term care assessments, infant home visitation, plans of safe care, immunizations, kind of your wide range of public health and direct care health services. The majority of those are state run. So we do run into issues with recruitment there. For example, in the past, we've had, in the area of the Bighorn Basin, sometimes you have one nurse manager of an office covering multiple counties. And that can be a strain both on getting the job done, but also on those particular nurses' time. But what we've really focused on, just because we're so data rich in it, and because of how this topic has been discussed with this subcommittee over the past month or so, we really focused on the consequences of our direct care vacancies at our 5 health facilities. And again, because there's so many upstream and downstream consequences of those staffing shortages or vacancies outside of the Department of Health, which I'll get to. So the populations that we're generally talking about, just to kind of reiterate to the committee, at the Department of Health facilities, I'll go through a few, but happy to answer any questions about the types of folks we serve at these facilities. Title 25, almost all Title 25 civil commitments. So these are folks who, not criminal, but have been emergently detained and in some cases involuntarily hospitalized due to mental health or psychiatric issues, dangerous to self or others. Those primarily, almost universally, are committed to the custody of the Wyoming State Hospital. In addition, at the state hospital, we serve what we call forensic or criminal forensic patients in Title VII. Those are folks who have been charged with or convicted of crimes, and for a variety of reasons, maybe the reason for that crime or not knowing that they committed a crime or have the competency to stand trial for their crime, can be committed for services on an inpatient basis to the state hospital in what we call our criminal justice services wing. And so that's Title VII. So Title 25 and Title VII, those generally flow towards the state hospital in Evanston. Both in Evanston, the Life Resource Center, the Retirement Center, now the Pioneer Home, and even the Veterans Home, we also serve clients that, this is a term that was put into statute years ago. It's very broad, but I think it's meaningful to folks who might be listening in today, are clients within those levels of care that manifest what are called exceptionally difficult behaviors. So you might have dual or even multiple diagnoses going on, but essentially the problem of why they can't be served elsewhere, why they've been discharged from other settings, or why they might be in the criminal justice system or the courts, is because of behavioral issues. So maybe mental health plus extreme behaviors, long-term care or dementia plus exceptional behaviors, things like aggression towards, violence towards others, violence towards themselves, those types of things. We deal with quite a few at all of our facilities, quite a few high behavioral clientele. In addition, I kind of mentioned this already, on the long-term care side, a lot of dual diagnosis. So again, mental health and geriatric issues. And I'll give you a few examples of that, where you can have folks who are in later stages of dementia, but also might have schizophrenia or some sort of psychosis where the day-to-day and the challenges and behaviors are exacerbated by multiple conditions together. And we see a lot of that both at the state hospital, the Life Resource Center, but also the Retirement Center in Basin. Veterans are another population, which obviously we have a specific facility at the Veterans Home, both in assisted living and in the last 2 years now skilled nursing beds at the Veterans Home in Buffalo. Those are the eligibility for that facility are, honorably discharged veterans, Gold Star families, those types of things where military service is kind of a prerequisite. And that facility is geared 100% towards the veteran population, of which there's no other, specific veterans facility around the state. That doesn't mean that long-term care facilities can't serve veterans and even receive VA funding for veterans, but we are the Veterans Home, state-run Veterans Home that is primarily dedicated to that population. We also have, this is more of an exception to the rule, but over the past, as long as I've been in this role and even prior, quite a few emergency placements. Again, it's more rare than the general populations we serve. But whether it's in working with Department of Family Services, Department of Education, the law enforcement system, criminal justice system, the courts, other facilities, we are sometimes the last stop on the road on emergency placements where there's nowhere else to go, or someone's, the outcome that we're seeing because there's no facility or placement that will accept a specific client. That could be an adolescent, that could be an adult, that could be an elderly adult. For a variety of reasons, we can admit to some of our facilities on what we call emergency placement authority. That's usually with my authority, the director's authority, and there's a few examples over the years of where that has happened and why that has happened. But typically, it's because there is an extreme emergency, and we have a few clients like that at the Life Resource Center where there literally has been hundreds of denials all over the state, all over the country for other levels of care or facilities, and the state ends up, doing what we can to design programming, housing, et cetera, at our facilities for that type of population.
Director,
Please.
Ask a question here. You mentioned other facilities around the state, and then you mentioned other facilities. I know that when my father was held in a private nursing home a few years back, he began to think he was Harry Houdini or something. Anyway, they couldn't hold him, and they sent him to a facility in Idaho. At the state level with ours, do we have any other states out there that cooperate with us that in an extreme case might be able to offer a facility?
Mr. Chairman, it's a good question. The answer is yes, but the situations that drive that are highly variable. So give you a few examples where for our Medicaid population, and many of these folks, either through Medicaid state plan or through our developmental disability waivers or other programs, might have Medicaid coverage. And our Medicaid program does maintain provider networks in our peripheral states and even in very small instances around the country. So when you talk about psychiatric residential placements for adolescents, we call them PRTF, psychiatric residential treatment facilities. We only have 2 in Wyoming, and so we do partner with providers in the state of Utah, for example, the state of Colorado, Idaho, even as far away as Arkansas. In their very select cases and usually specialty care that a child needs for a specific diagnosis or something specific with the autism spectrum, for example, where that specialty either doesn't exist or there's not an open bed within our state or within our region, and we will work in a provider network either from providers that are enrolled in Wyoming Medicaid that happen to be out of state, or in some cases what we call single case agreements, where we essentially contract for one single case, one single placement in Medicaid for that specific facility. And there's utilization review that happens, pretty frequently and periodically to either prior authorize or reauthorize that service. So what I'm driving at there is it's not something where we say, okay, great, we found a placement in Utah for this child, and now we wash our hands, and there's a lot of follow-up that happens around, is that level of care necessary? And then, Mr. Chairman, outside of Medicaid, the answer is also yes. So for example, we participate in what's called an interagency children's collaborative, which is in statute, which is in partnership with the Department of Family Services and the Department of Education, where some of these crisis cases, significant extreme crisis cases, in this case with children, they don't fit neatly into buckets of coverage or service that DFS has, that Department of Health has, or the Department of Education has, usually driven largely by their conditions, but mostly by their behaviors, again, violence, self-harm, those types of things. And we work as kind of a triune agency group to find appropriate placement for those. And again, similarly, through negotiations or partnerships with other states and providers in other states, we will find, hopefully, and it's a challenge, but find placement out of state in those cases as well.
Thank you.
You bet. The last kind of population group that I wanted to mention, and this is more specific to the retirement center in Basin, which is a skilled nursing facility. We do have 2 locked dementia units at that facility, and the acuity of clientele we serve there, relatively speaking, is high compared to the industry average. And the reason I bring that up is we've positioned the retirement center, as many of the staffing challenges as we have at that facility, which we'll get to in a minute, to operate over the years more in a safety net manner, meaning it was not established in the state or in statute as a pure safety net facility, but we've moved it in that direction because of the need that's out there. So as an example, the retirement center often considers, almost every week, what we call involuntary discharges from other long-term care facilities, meaning a private or a county-owned nursing home around the state is having trouble or can't deal with or won't deal with a specific client. Again, think advanced dementia, more extreme behaviors, those types of things, and they can, by their totally above board and totally legal, issue an intent to discharge. Usually that's a 30-day notice to that client that they're going to be discharged. This facility will not serve them anymore. And we are one of the referrals in Wyoming, one of the referral entities that will take those applications or referrals and really consider them, and in often cases admit those clients because we want to be that safety net. So that's outside of the legal system, outside of Title 25 or Title 7, but a landing spot that we have seen grow over the years with the retirement center, serving and treating, providing long-term care to a higher acuity clientele. And again, that's been a challenge because those challenges are exacerbated by what you'll see and what you saw in that brief of the staffing challenges that we have at that facility. Next, Mr. Chairman, talk about our customers a little bit. And I'll be very brief here because you kind of sensed that in where I'm going with this theme. We talked about our facilities. We talked about some of the populations that those facilities serve. In addition to those people who are our main priority, the people that come to our facilities, the people that live in our facilities, those are our main customers. But I think it's important to reiterate and mention who we're really serving in the system of care around the state. Our courts and judges, law enforcement, so sheriffs, jails, detention centers, jail administrators, hospital emergency departments, other facilities like I just mentioned who might be unable to care for certain types of populations and are discharging those or want to discharge those populations. Those are really kind of at a system level, the Department of Health's customers. So what we've talked about the past 2 meetings is very true, that when we don't have beds available at the state hospital, for example, but even at the Life Resource Center, the Retirement Center, et cetera, we will see challenges, those challenges kind of transferred to those other systems. So in Title 25 and Title 7, you will, if you talk to your county attorneys or your district and circuit court judges, they will tell you that they are in high demand for state hospital services. The wait list is a challenge. The lack of available beds is a challenge. The staffing issues are a challenge because those cases pile up. And in those cases, we'll take Title 25 and Title 7 as an example. When those wait lists are there, those clients are either waiting in an emergency department or a hospital inpatient setting in any of our communities. So think, Cheyenne Regional, Ivinson Memorial, North Bighorn Hospital, who might have a Title 25 client in their emergency department or admitted to the floor in an inpatient unit, but are literally just being held there. Maybe some medical services, but not often, the type of psychiatric services that we would provide at the state hospital are waiting for admission to Evanston. On Title VII, for those clients that have been charged with or convicted of a crime and have been committed to the state hospital on an inpatient basis to be restored, to go back to the criminal justice system, those clients are essentially waiting and being housed in jails and detention centers. So your sheriffs and your law enforcement system are also they have a very high demand for the state hospital services as well. I mentioned, hospital emergency departments as well. Excuse me, it looks like Representative Sherwood has a question.
Thank you. I guess just more of a confirmation there. I did visit with our county sheriff last week about this issue in particular. And I think one of the most disturbing things that he shared with me is that sometimes there are individuals who end up waiting in our county jail longer, more days than if they had been sentenced and what the maximum term of that sentence would have been. So this is a great disservice to our community members when we have failed to address the wait list. So I appreciate that this committee is discussing this as well as our friends on Joint Judiciary.
Thank you.
Okay, Mr. Chairman, I'll point you to the first brief that we sent the committee. It's a short 3-page document titled Safety Net Facility Direct Care Vacancies and Consequences. I'll point you to page 2. This is data that you've seen, but I wanted to highlight a few elements. And Mr. Chairman, obviously before December rolls around with our budget hearings in front of JAC and going into the session, this will obviously update these data. We typically get the monthly, can put together the monthly data about a month or so after what we label the chart as. So this data is kind of as of mid-September, but it's labeled August 2025 because it goes through August of 2025. And what you'll notice here, we've carved it up into 2 buckets. So it's all direct care, nursing related. The first row are your CNAs. And the second row are all of your nursing staff. So licensed practical nurses or LPNs, registered nurses, or any advanced nurses that we have in our classifications. And then the second column is all of those facilities that we just talked about. So the Life Resource Center, Pioneer Home, Retirement Center, Veterans Home, the Veterans Skilled Nursing Facility, and also the state hospital. And you can see the vacancies and the total number of positions as of the end of August on your next two columns, and the overall vacancy rate within those types of positions in the far right. So you can see at the Life Resource Center with CNAs, as of the end of August, we were 67% vacant on those. At the Retirement Center, 58% vacant. At the Veterans Skilled Nursing Facility, 53% vacant. And again, as we talked about last meeting, a little bit of improvement over the last 12 months at the state hospital, 17% vacant on CNAs, really due to the good work of our director of nursing there, recruiting a lot, partnering with community colleges, hosting clinicals, really some good work to lower that entry level CNA vacancy rate through a lot of recruiting efforts. On the nursing side, so the bottom half of that chart, you can see at the Life Resource Center with nurses, 58% vacant. A very scary number at the Retirement Center, 72% vacant on nursing positions. At the Veterans Assisted Living Facility, 56% vacant on nurses. Veterans Skilled Nursing Facility, 36% vacant, and just under 40% vacant on nurses at the state hospital. Real challenge with especially on the entry level nursing side. What you'll see in our budget book and A&I's budget book classified as HSNU 08s. Those are our typically our entry level nurses are either 06s or 08s. 08s is able to be a registered nurse, but still that entry level nursing position. What I haven't mentioned yet, but that I did want to point out, is two rows on this chart that say 0%, which is really, really good, and that's at the Pioneer Home. So again, about a 45-bed assisted living facility in Thermopolis. And the team does Julie Hoffman, our administrator up there, and her leadership team just do a remarkable job with that facility. It's a wonderful facility if you ever get the chance to visit it. But for the past several years, mostly as long as I've been director here, going on 5 years, she's done a great job keeping that facility fully staffed. And as much as I would just want to compliment her ad nauseum, because it is true, I want this committee to understand that it is a very different type of facility than the state hospital, the Life Resource Center. Historically, not as challenging of a population to serve, doesn't take the kind of staffing levels that you need when you talk about a 2-on-1 staff to client ratio, because you have dangerous people, psychotic people. But at the same time, I think there's also a cultural element there of, folks like to work at the Pioneer Home. It might, on the direct care side, it's hard to say that it's an easier job, but I think the day-to-day of what you deal with and the stressors that you deal with are just different than the day-to-day at the state hospital. But again, it's important to point out the wins here, like we talked about with the state hospital and their CNA vacancy rate. Pioneer Home has done an excellent job keeping fully staffed. But again, much lower staffing footprint at the Pioneer Home, much lower staff to client ratio. So just a different type of facility. And it's worth mentioning there, Mr. Chairman, that in addition to what I just mentioned, over the past 3 or 4 years, the Pioneer Home has also done a remarkable job positioning itself under our direction, but also with a big partnership among the Department of Health, with my office, with the state hospital, and with Pioneer Home leadership to serve a much higher needs population. So over the past 3 or 4 years, we have actually admitted and successfully served several state hospital discharge clients at the Pioneer Home. So elderly folks who absolutely have psychotic and mental health conditions, but are really, we believed, could be successfully served in this assisted living facility. And Julie and her team have done a remarkable job creating an environment and making that environment a place where you now can live more independently, more successfully outside of a locked facility like the state hospital. And that has been a relatively new mission for the Pioneer Home, also for the Retirement Center, that we have been excited about, but also recognize the challenges in making that happen. Mr. Chairman, I'll have you flip to the next page, which shows a kind of an eye chart, but it's figure 1. And this is the position I mentioned, HSNU 8s, or basically entry-level nurses. That's the MPP, kind of the market price that you'll hear about in, when we talk about state government staffing. That's kind of usually the target based on where the pay tables are. And I know Director Bach and Administrator Williams can speak to this probably more granularly than I can, but it's often a range that we're bouncing off of. Where are we in relation to MPP with all of our different state government positions? And this kind of shows you where our HSNU 8 MPP, based on the current pay tables, which I know are dated. I think we're on the 2022 pay tables right now. How that compares to both the median and the 75th percentile, kind of in the market distribution of what we see for similar types of positions. And it just gives you a sense visually of where we are and also where the market has trended for a variety of reasons. Some of which we absolutely do not control. It's just what the industry in our region or in the country is paying for that type of labor and where Wyoming stacks up. So it's just a visual to show you that you can never be perfect here, but over time those models of where we are in relation to similar facilities or industries, it just slips over time, and we're certainly feeling that at our state facilities. And last but not least, Mr. Chairman, Table 2 on page, I believe it's page 3. I want to once again reiterate, what do we do when we have those vacancies? And this has been a challenge for me as a director for our department in general, is we could kind of in a nuclear fashion say, okay, we do not have the recruiting or the staff on the state positions, CNAs, nurses available. Therefore, we are going to take beds offline at the state hospital, at the Life Resource Center, the retirement center. I have struggled to make that decision because of those upstream and downstream impacts and customers that we talked about before. Your courts, your law enforcement entities, your hospital emergency departments. If we just take 20 beds offline or 25 beds offline at the state hospital because we don't have the staff, those Title 25 and Title 7 wait lists will grow exponentially. And the result of that is you have folks waiting for months and months more in hospital emergency departments, in jails or detention centers. So somewhat reluctantly over the years, we have, which any 24/7 facility will do elements of contract labor. We have made the decision to, as best we can, to essentially buy contract labor, buy nurses, traveling CNAs from various contract labor companies. Generally, any facility, as I mentioned, will do this from time to time because of different types of staffing issues or retirements that you have. You always want to have the ability, to bring in agency labor, to bring in contract labor from time to time. But as you can see from this chart, broken out by facility and broken out by fiscal year, you can see some pretty extreme growth, and that has a variety of factors related to it. Mostly is because of the inflation and the pressures we've seen in the nurse and nurse-related market going back to 2019, 2020, where those prices and the demand for contract labor just became so exorbitant that the price per unit essentially grew exponentially. And so traveling nurses and traveling CNAs from these staffing companies just became more expensive. And I won't belabor the point, you guys heard it the last two meetings, but typically we're seeing between $70 and $80 an hour for a contract nurse and around $45 to $50 an hour for a contract CNA. That compares relatively to what we're paying an entry-level nurse right now in the state of Wyoming Department of Health is $31 to $33 an hour. And at a CNA, around $17.90 to $18.90 an hour for CNAs. So a big discrepancy there. And obviously we expect a premium when you go buy a contract nurse or a contract CNA. But those prices have really grown almost in order of magnitude just in the past 5, 6, 7 years to be very expensive. So you can see that pretty robust growth on page 3 there in that table, where in fiscal year 25, we spent just under $17 million on contract labor across all of our facilities. The primary users of that are the retirement center, the state hospital, and the Life Resource Center. Very minimal and largely due to retirements and staffing issues at the Pioneer Home. We've had a minimal amount of contract labor over the years there, but mostly just to fill holes temporarily. You can see it's more systemic at those other 3 facilities where it's really just grown quite a bit, especially since around 2021. You've seen pretty exponential growth there. And again, it's all related to our decision and our want to keep beds available for those customers that I mentioned. And I'll close, Mr. Chairman, by just mentioning that the mechanics of how we do that, because it's often asked of me, and I think it's a really good question. How do we finance that level of contract labor at our facilities? That seems like inordinate growth. How have we not come to you with a budget request? And the way the mechanics work is we take those vacancies, those positions, nurses and CNAs that are vacant, and we essentially pool that 100 series because we're not spending that. Those positions are not there. Then we essentially convert those 100 series to contract costs, and we use those funds to pay those contracts. And you would say, well, if you're only paying $31 an hour for an entry-level nurse, how are you then turning that $31 an hour into $80 to buy a contract nurse? And that's where that sort of limiting factor comes in with how many beds we can keep available. Because we can take those funds, we can't buy one-to-one. For the nurse positions we have, we can't contract for a nurse because of that price discrepancy. So we essentially contract for a smaller amount of staff at a higher price, and we still have beds that are unavailable or offline because of that discrepancy. So at the state hospital, even with the growth in contract expenses, we have a 104-bed physical plant at the state hospital in Evanston. We are effectively today operating an 80-bed facility. So we have essentially 20 to 24 beds offline at any given time because of that. Again, it's not a one-to-one because that contract labor is so much more expensive than what the budget is in those specific state positions. So as you heard our CFO, Eric McVicker, describe in our last meeting and when we met in person in Casper, him and I over the past 5 years or so, we take all of those vacancy savings. And in fact, we take projected savings from the Department of Health's general fund. And in any given fiscal year or biennium, we essentially project that every month and we lock those funds down. So we try to limit that, which I don't like to think happens in my agency, but it is somewhat natural to, you have programs or units that you want to spend your budget. But given crises and situations like this, we've known over the years that if we need to have those funds available, we have to have some due diligence in my office and on the fiscal side to make sure that if you have 100 series vacancy savings or projected general fund savings budget that you're not going to spend, and in some cases may not need to spend because we're meeting our program objectives, we try to do the best job we can of locking those funds down so that in situations like this, we have those funds available to be able to serve the courts, the jails, et cetera, with expenses like this. Even if it's, again, reluctant. This is not something I want to do. I would love to have our facilities staffed with good Wyoming grown state staff in these positions, as opposed to out-of-state contract companies that send us nurses or CNAs for 3 months or 6 months or 9 months. It's definitely a preferred option to have the former versus the latter. But Mr. Chairman, I know I took a little bit of liberties there. I wanted to be brief with the overview. Given the other agenda items you have today, I'm more than happy to stand for any questions and certainly defer any time that I have over to our esteemed A&I Director, Tricia Bach.
Thank you for your comments, Director. I'll ask for questions in just a second. I just wanted to make another statement. We talked last week or last time we met about the self-licking ice cream cone kind of situation where nurses ask themselves, why should I work full-time for X amount of dollars when I can work 1 week a month and make the same money? And that's a good question. I know that nothing against the traveling nurses, it's a very challenging job, but those who are residents who know the clients, they're with them every day, they live among them, they're going to provide better care.
Yep.
They just instinctively they're going to know the patients better and the residents, and so that's definitely where we want to go. So then the reason we asked for A and I, of course, and this is more for the benefit of those listening, was where's that magic number? You know, how much are we going to have to pay somebody to convince them to stay put and actually enjoy a better lifestyle and not have to travel around? And that's where A and I comes in. But before we bring them on, are there any questions from the committee? Yes, Representative Sherwood.
Thank you, Mr. Chairman. I think we are on the same page. Very interesting to see the modeling about, what wage should we be paying so that we start saving money by reducing what we're spending on contract labor. So thank you. Thanks for this conversation.
Thank you. That's obviously one aspect, but the other aspect is we get more total personnel by using our own rather than the contracts because of the exorbitant difference. So we could actually keep more beds open. And that's part of the underlying purpose of what we're trying to do here. So Senator, any questions?
Oh, just, well, thank you, Mr. Chairman. I would guess one of the issues on that is when you got to raise it for everybody, obviously, not just the entry. So that's where the big cost comes, I'm sure. And it'll be interesting to hear what's said here. Thanks.
Excellent point. I believe we are finished with questions, so let's move on to the A&I team.
Good morning, Chairman, members of the committee. My name is Patricia Bach. I'm very happy to be here with Aaron Williams, the Human Resource Division Administrator. Just a little bit of background for your information. I served as the Human Resource Division Administrator prior to Aaron Williams. She was in the Human Resource Division for 20 some years prior. When I moved up to the director position, I moved her over to the Human Resource Division Administrator. And so we both have a pretty good handle on what the landscape has looked like for the past 15 years, at least. So what I wanted to, I'm gonna be brief because I think Aaron's gonna have a little more detail for you. What we do at ANI in the Human Resource Division with the pay tables and where people sit in those pay tables. A lot of times what happens is people are like, well, ANI has this number and that's what you have to pay. Most of the time, we are willing to go all the way to max, like for Stefan and his nurses. However, they don't have the budget. That's where the problem comes in. So what we have done in the past 4 years with the pay tables is if Representative Sherwood has sat through my discussions of the matrix and a very complicated way that we have tried to move people through the pay tables. So what we are doing now for this coming budget, hopefully, it has to get approved through the governor's office. So this is not necessarily for prime time, but we are working on looking at just changing the pay tables to the current, what we call current, which is actually a year behind at 2024. So if we move the pay tables to the 2024 pay tables, right now we're on 2022, working with Director Joe Hansen and his team, our numbers are extremely close to what he has essentially asked for. So we're looking, I believe, Director Joe Hansen talked about a $39, $40 an hour. That's pretty much where our pay tables will be if we move them to the 2024 pay table. And what that means, so say, for example, Director Joe Hansen is on, one of his staff is on the pay table and they're at MPP at 2022. And we move the pay table to be current to 2024. We will keep that person and move them over at MPP. So it's a compa ratio. So not everybody's at MPP. We have a lot of folks that are at 90% of MPP some people a little bit over MPP. Wherever they land on the 2020, wherever they are right now on the pay table, the compa ratio is what we call it. We would move them to the compa ratio of the 2024 pay table. Not only will that fix probably 90% of the problem that we have, not only with health, and I know we're focusing on health, but we're talking about snowplow drivers, electricians, everybody on the pay table. That fixes the majority. The ones that it doesn't necessarily fix, because there's always some outliers that, there might be some nurses that really have been here for 20 years at the Pioneer Home. And we need to make sure they're not getting paid the exact same number that somebody directly out of school is being paid. Then we work with them and make sure that that's adjusted. We call that compression. And so we work with that. But this coming session, I'm hopeful that we can talk a little bit more about moving the pay table, and it's not a complicated matrix issue that the JAC has to listen to, that they've listened to for the past 3 years. So moving the pay table is quite simple. And that, like I said, it's something that the governor will have to approve through my budget. I had my budget hearing, so we'll find out exactly what that looks like when the governor comes out with his budget. But I just wanted to make sure there's a little bit of background there and what hopefully you will be looking at the JAC, and we can talk a little more about it there. But the $39 an hour, and I'm going to turn it over to Aaron to talk a little more specific with health. I did put in the chat the workforce report, ANI's workforce report. We will have that for you at the JAC. We'll print some for you so you have it. And that has just been published in the last week. So that gives you kind of an idea of the vacancies all over the state. So just for your perusal when you have extra time. And then we can talk about that at the JAC. But if you have any specific questions on kind of what ANI does and how that works, I'd be happy to do that. Otherwise, I'll turn it over to Aaron.
I do have a question, Ms.
Sure.
Block. We're talking about jumping 2 years, essentially from 22 to 24.
Yes.
What is the overall cost of that? What's the price difference, or to the state?
It depends on how you look at it. It is some of the positions are 15% back, even though we've done a lot of work in the last 4 years. Some positions are 7% back. So it's all dependent on what that market is for that position. For example, nurses are significantly behind. However, directors are not. So that's kind of how it looks. So there's most of the movement is going to be at the bottom of the pay table, which is where it should be. Right. And that's how we have done it in the past 4 years. Representative Sherwood would remember that we moved everybody there's nobody in the state that is paid less than $15.50 an hour. Prior to that, a lot of my guys on the grounds and the custodial department were making $11 an hour. So that biggest move is at the bottom of the pay table. I can work with the governor's office and make sure that I can get you that number, but since it hasn't been approved, I can't really go through that with you. Yeah. It's not cheap.
When the time comes, I definitely would want a price tag.
Absolutely. Absolutely.
What's it cost us to bring everybody up to 24? Okay.
And I can talk with the governor about that and make sure that because since he hasn't approved it yet, I need to make sure that whatever he has decided to do, then as soon as that is decided, I will make sure because the JAC is where it is that I'll be discussing it.
Look forward to hearing that.
Yes. Thank you. And I'll turn it over to Aaron now so that we can talk specifically about health.
Go ahead, Ms. Williams.
Yeah, Chairman and members of the committee, I appreciate your time this morning. Representative Pendergraft, you had kind of asked, cost, and I don't have that, but I do have percentages. And it's really exciting to see, even though we're still behind and we're not on the most recent pay table, we really appreciate the legislatures and the governor's office assistance in the phase 1, phase 2, and phase 3. We do have 5 different pay tables. And so the market lag on average overall on all of those pay tables is 8.7%. So phase 1, phase 2, and phase 3 has really helped our position in range with the market. The general pay table with all the work that's been done is lagging about 5.7%. And the executive pay table to Director Bach's point is 6.4%. Now, the areas where we're still really struggling and really behind market is the nursing pay table, which is really relevant for this conversation. The current market lag between the market numbers we're on now, 2022 and 2024, is 21.2%. The attorney pay table is the other one where we're still lagging quite a bit, and that is 17.9%. So as Director Johansson mentioned, we've been working hand in hand with his office. We understand the concerns that he has recruiting and retaining, even with all of the work that's been done. Just based on the market, there is definitely things going on in the industry that are driving this substantially. Specific numbers relevant to, I think, the HSNU 08 is where we spend a lot of our time. So Director Johansson mentioned that the current market policy position, and the reason that the Human Resources Division really revolves our policies and everything around that rate, is that's where the positions are budgeted at. So the state budget department, when agencies get a new position, we give the agency the dollars for that market policy position. So an agency really doesn't have the latitude to go above that. That's the rate they were given for that position. So currently that's $34.27 an hour. Now, agencies aren't going to put everybody there. To Senator Larson's point, you're going to put new employees a little bit lower. So as Director Johansson testified, he has employees between $31 and $33 an hour, with that MPP kind of being the target where we hope to move, employees closer to that mark. The maximum of that pay table currently is $41.12. So if Director Johansson were to come to the Human Resources Division and say, I need to move my entry hiring rate, we are bleeding, I need to move that to $39 an hour, the Human Resources Division would approve that. We would have the authority to do that within the pay range. However, to Senator Larson's point again, hiring new employees at $39 causes compression. We would have to move everybody in that $31 to $33. So that's exactly the issue that Director Johansson and his team are facing. HRD can make exceptions all day long, but if the funding isn't there, it really ties the agency director's hands. The new market data.
That's what I'm trying to get at is, the relative scale. Because obviously, if you've been there 20 years, you need to be rewarded for that.
Correct.
So that's what we're trying to get at is what are we looking at cost-wise?
Yeah, and I think, with Director Bach's request that we have put in to move to the new pay tables, the 2024, the new data would look like the market policy position would move from that $34.27 an hour to $40.46 an hour. So that is right in line with where Director Johansson's numbers were showing, that $39. So the market analysis that the Department of Health does reinforces what the Human Resources Division is doing and our market data that we run. We're hand in hand. The fact is, just in the executive branch, we're a few years behind. If we were on the tables that we needed to be, we would be right where Director Johansson needed it to be. Then the max on that would increase to $48.55. And so depending on, how Director Johansson chose to fill those positions and the new hiring rate, he would have some flexibility in the range.
Thank you.
I also did just briefly, unless there's not any more questions on the market, if Director Bach's recommendation is approved on the pay table movement, average employee increase for nurses would be about 16%. For the HSN 8, that would be about an 18.1%. So just really shows how drastically far behind market those individuals are, but still half as much as what we're paying on those contract nurses.
And I would mention, just to jump in here, one of the things that I've been attempting to discuss with the JAC, and maybe this year will be the year to talk about it, is the more that we keep closer to the market each biennium, the lesser that number is going to be as a shock. So, you know, a lot of times, like, well, why don't we just do an EAC, you know, just do a percentage increase? The problem is, and I will be the first one to admit, if you said, okay, let's just make everybody get a 3% increase. And the problem is, my 3% increase is significant. My custodian's 3% increase is not. That is a very small number. So that's why we go through the pay table system and look at all these numbers, so that we're not looking at the top of the pay table. Because the top of the pay table isn't where the problem is.
Right.
The first 50% of the pay table is where the problem is. So moving the pay tables consistently offers a smaller amount. You know, if we're in an right now, we're in a difficult time with how quickly these pay rates are going up. And I know you're all pretty much aware of the companies that are coming into Cheyenne, which is great for employees. It's really bad for me, because what happens is I have all the trades folks. So I have electricians, HVAC, carpenters, plumbers. My vacancy rate for the electricians is 51%. So we have 2 electricians right now for the entire state. And they can go from my office, where I'm trying to scramble to keep them, and they can go to Meta for $70 an hour as a journeyman. That's not even a master. So that's the concern. And the contractors in Cheyenne are having the same problem. So we can't even go out and contract with, you know, get a as needed contract for electricians, because there are none. They're all going, I mean, they're going to better themselves, but they're going to get burned out because they're working them 60 hours a week, 70 hours a week. They're not using IT. They're keeping IT in Silicon Valley, and they're teleworking. And so they're not using our IT, but they're using all of our trades folks. So those are the issues that we have. And nursing is not unlike that problem. It's a little different problem, but it is very similar. Eventually, we're not even going to be able to contract them. And I don't know what we do at that point. And that's what's scary for Stefan.
Yeah.
Sorry, Director Johansson.
Chairman and committee, I know Director Bach also shared with you the workforce report. I do just want to point out all of the great work and the graciousness again for the approval of the phase 1, phase 2, and phase 3. Before we began implementation of those increases, the state of Wyoming turnover was the highest I've ever seen it in the history of my 26-year career at 22.8%. That was without any of the transfers agency to agency. That was just people leaving state government. If you look at the turnover that we see within agencies kind of stealing each other, or employees moving to another agency for a promotional increase, you know, that rate was even higher. It was upwards of 24.8%. After phase 1, phase 2, phase 3, we have decreased that turnover down to 14.8%. We are seeing with our new numbers that's trending back up a bit, just because of the things that we're talking about here. So we're sitting at about 15.6%. And so just as part of Director Bach's and my testimony in the A&I budget hearing, we do not want to lose any ground of all of the hard work that went into phase 2 and phase 3. If we were to move to the pay tables, and rather than accepting the recommendation as Director Bach put forth, say we decide to say, oh, we're just going to move everybody to the entry of that pay table. Well, as we're seeing with these pay tables on average 15 to 17% behind, we would lose all of the ground that we have made in the previous increases, and we would be starting back over, and we'd be asking you for phase one, phase two, and phase three all over again. So what in essence we're asking is just to help maintain the position and range where we are now, but on the most up-to-date pay tables. And like Director Bach mentioned, we're seeing if we do that, we'll still be lagging a year behind market rates, but we'll be competitive. We'll be where the agencies. We have Director Bach needing to pay a certain rate for engineers. We have YDOT. We're working with them on the pilots. The nursing situation with Director Johansson. We can't do some of the things we need to do now on this old pay table, but we'd be right in line with the approval of the new one. So the numbers are just, like Director Bach said, a lot easier to understand. We've done all the hard work with the matrix. We've worked to ease the compression. And so moving to this pay table to like compa ratio, I think would keep us in a really good position where we need to be.
But we don't know what it costs yet.
I am going to get that to you as soon as I can, Representative.
Thank you. Are there any further questions for Representative Sherwood? Go ahead.
Thank you, Mr. Chairman, and thank you guys for this information. I appreciate how things are aligning, and hopefully we're all headed in the same direction in terms of good policy and problem solving. I guess my question is there somebody, I don't know who this should be directed to, somebody who's like an IT economic projection wizard. Is there a way to model the savings in terms of like, so if we adopt this 2024 pay table and we make the adjustment for nurses, modeling then on the back end how much we then save on contract labor, just because I would love to have that information for our colleagues in terms of the head data needed to understand why we need to pay more to save on the back end. Thank you.
And I think that I wouldn't be surprised if Mr. McVicker and Director Johansson have that number for nurses, or they can get it very quickly. I think that it's helpful to do it for all of them, for the entire state. And so that's something we will make a note of. We have meetings with all of the directors every third Tuesday of the month, and we talk about these things. And if we can get the CFOs on the line, then between the CFOs and HR, we should be able to get that number for each agency. So that is a very good question. And I think it is very helpful if we have that.
Thank you so much for already thinking ahead to that. And I realize too, there's also the costs associated when those positions are vacant, right? So the cost of not providing services, and then the cost associated with retraining and what that takes to get somebody back up to speed.
The average cost for, I'm sorry, I'm being very Representative Sherwood. The cost for filling a position that's been vacant is approximately $12,000 per employee that comes in. And if that number has changed, I will double check it. I can't imagine it went down, but we will look to see if that number is still the same. And that was a couple of years ago when we were going through phase one, phase two, and phase three that I had that number in my head.
Thank you, Ms. Bach, for recognizing decorum.
I'm sorry.
No,
it's hard, Representative. It's hard when you're on Zoom, and
it
it
is, and we're also, this is a very small committee.
Yeah.
And
I apologize.
We're trying to work. No apology necessary. We're trying to work as smoothly and efficiently as possible, and so I'm going to be a little bit gracious.
Thank you.
On that record. I don't think anybody's taken advantage of it, and we're not getting into a direct one-on-one that is in any way hostile. So I'll grant a little bit of leniency there. I will also grant Director Johansson the floor.
Thank you, Mr. Chairman. Just in response to Representative Sherwood's question, the simple answer is yes. We can, and there's a couple of different ways you could look at that. So on the macro side, and we've looked at this as well, you have to, if you were able to, raise, the recruiting salary for those nurses and CNAs, You then would have to estimate at what rate do you fill those positions? And there's a lot of assumptions that can get baked in. So at a $39 or $40 an hour wage for those entry-level nurses, what could we anticipate the number of vacancies that we would eliminate, right? That would be your first number. And then your second number is, by nature of the first number, how many contract nurses could you then eliminate at that price that we're paying? So you could get a sense of, the I would call it the gross savings there, but we need to look at net savings, because, as was discussed before, you don't want to get into a situation where the nurses that you're starting to recruit are now at the same wage of a nurse or a CNA that has had a lot of longevity at the facility. So you're really talking about raising all of those boats, which then has a bigger price tag around it. The way I like to think about it is, we are trending right now in the Department of Health and these safety net facilities at, as you saw in the table in your briefing document, at a pretty substantial increase year over year in contract labor. So the investment in salaries now, yes, at a much lower hourly rate than the contract costs, over a longer period of time, with an expense up front, you could see those contract labor costs reduce. The net savings are harder to get at, because you have to bake in those assumptions. So what I hate to do more than anything is to sound like a used car salesman and say, if you buy the rust coating now, you'll save all this maintenance cost down the road. Trust me, there's savings there, because I think there is just absolutely a raw investment that has to happen to raise those pay tables. But I think the measures that we would look at, and we'll be prepared to discuss this at JAC as well. I don't want to get out ahead of the governor on the budget recommendations that will come, in less than a month's time. But we'll be prepared to discuss those exercises, Representative Sherwood, and what we could, help the committee with in terms of different ways to look at that long-term forecasting. We have a lot of those exercises prepared, and we've done them for previous committees when you were considering compensation adjustments before. But it is, I think the last thing I'll mention that's a good way to look at it is in those, and we're looking at this now. We don't have the numbers prepared for you today, but can have them shortly. When you look at that table that shows our fiscal year 2025 contract labor, backing that out and saying, okay, how many nurses or CNAs did that buy, can give you a good sense of what would we have been able to purchase on state staff at whatever wage that we are paying, whether that's my current wage or an increased, 2024 market or 2024 pay table wage. You could get a sense of your cost offsets there. But again, I think it's really important for the committee and the JAC to understand that you're really talking about that macro picture. It's just like my staffing issues. It's not a one-to-one between state staff and contract. And the same way, if you raise the pay tables, you can't just do a simple exercise and say, okay, we're not paying $70 an hour for a nurse or $80 an hour for a nurse anymore. We're paying $40, and then just do the math that way. You really have to look at your overall staffing levels, what the increases look like across the board, and then essentially how successful we are in that recruiting, which would take time to understand. Thank you, Mr. Chairman.
Yeah, thank you, Director. Points well taken. I think from where I sit, the question, what does it cost, and then what are we buying for that? And what we're after is, how many beds are we going to be able to free up or keep open, as opposed to maybe having to ship someone to Idaho or Utah or those options. So those are the things that we need to understand to be able to make good, judicious, what's the cost and what are we getting in return for that. So.
And Mr. Chairman, if I may, because it's such a good point, in those discussions, and we've talked about it in this committee and in appropriations, and in fact in judiciary as well, this interim period, I think if the committee ends up considering actions like this, I'm just speaking for Department of Health side, there are performance metrics that we would absolutely want to be held to. For example, if we were able to fully staff in an ideal world our facilities, what should our wait list at the state hospital look like, right? What should our wait times for jails and detention centers and hospital emergency departments look like? Because we want those to be, reference to, okay, you're fully staffed. And that doesn't solve the full universe of problems, because even if we were fully staffed, at our facilities, the demand from the courts and the types of mental health orders we're seeing would still outpace that. But you should see a marked reduction if we're successful in recruiting in that wait list, where you could have your Title VII wait list, for example, drop from 4 to 5 months, to what we would really like to see is that 30 to 60 day time frame. So I think they're in discussion, if that comes up this December and going into the session, we'd be absolutely thrilled, Mr. Chairman and Representative Sherwood, to present those data and that type of modeling and projections to the committee.
Thank you. That would be helpful. I see A&I's hand raised, but I don't know which of you is.
Yes, thank you, Chairman Pendergraph. I just want to make sure, I want to let you know that what we will do at the next job workforce is let the agencies know, so that everybody has the benefit if they want to come in and say if they do have contract work. Because it's not just health. There's quite a few that have 900 series money for filling in for positions that they have that are vacant. So I will make sure that they know your request and make sure they have it there. So if you have questions specifically to their agency, that they'll hopefully have some numbers for you.
Thank you. Appreciate that. Representative Stivar, if you're sitting at the dais, you must be behind the post from my angle. But if you're there, you have a tremendous amount of experience in labor health, and I would like to offer you an opportunity to pose a question or make a comment.
Thank you, Mr. Chairman. I'm good at this time. I'm just listening and learning.
Thank you, and thank you for being here.
Mr. Chairman.
Senator Larson.
Yes. Could A&I maybe or Tricia maybe explain? We talked about the contract labor at what, $70-80 an hour, and we moved our employees to around 40 or whatever. There is a cost for the benefit that the employees get. So, is it going to make it like 60,000? Is 1.5 times their wage about right? So that's got to be factored in too, I guess.
Chairman Pendergraph, Representative Larson, it's a very good question. And I'll give you an example of the reason why I've been able to keep a hold of my 2 electricians and a couple of HVAC folks is because they've been here a while. Their pension is one of the reasons why they would want to stay. The problem being is the new ones, that's not an issue for them. However, we can give you the total comp package, and I'm sure Aaron has a general idea, but we can have that number for you. It is a significant number once you've worked for the state for a little while. If you've only been here for 1 year or 2 years, that number is significantly less than somebody who's been here for 20 years working as an electrician. So we can have that number for you as well. Do you have anything that could add to that?
I don't. It depends on the family, and like Director Bach said, the existing employees, we're going to have that already budgeted in through the state budget department, but I can give you some total comp costs of how all those benefit percentages would break down. We have a sheet that I'd be glad to send.
Thank you
for that. Cost of labor can't be separated from just their salary, obviously. Any other questions from the committee at this time? All right, seeing none, is there anyone with public comment either present here or waiting in the wings that I can't see? Yeah, I see no further comment or no further questions. I'm going to break for about 10 minutes and come back then and begin on the health stat. So about 5 minutes to 10, if we would all be back, and we'll start with health stat. Is that acceptable there? Right,
Thank you very much for having us here. I appreciate it.
Absolutely. Thank you for being here. I look forward to seeing you again here in a short bit of time.
Great. Thank you.
Yep. All right, waiting for the committee to show their shining faces. Welcome back, everybody. To those of you who may be out there watching, I would highly encourage you to look at the meeting materials and scroll through those to, I think it starts on page 8, is the health stat report. We're going to be walking through that, and I think you'll find this a very useful resource. And I would ask of the director, as we go through these things and we talk about the different topics, for example, legal services, legal developer, I notice is flagged as a federal mandate. As we go through each of these things, I would like to know what is federally mandated and what is an optional program. So that would be helpful. And I believe there's been a document put out that handles some of that, but I think as we walk through it now, that would be helpful. Director.
Thank you, Mr. Chairman. So appreciate the time on the agenda to talk about something that always excites me. One of our passions here in the Department of Health for the last 15 years has been the performance management around our programs. So if it's okay with you, Mr. Chairman, I plan to just give an introduction to what HealthStat is, where it came from, kind of how it functions. And then given that this is a 200 and almost 240 page document, I don't think anybody would like if I walked through every single page of that. So what I've done is selected a few examples from each division, not only to give the committee a sense of what's included in our health stat reports for each of our Department of Health programs, but also it gives you a sense of how we structure performance management at this high level for each one of these department functions. So, Mr. Chairman, to your question, more than happy to go into greater detail, whatever the committee would prefer. And it is a very mixed bag on functions, programs, et cetera, that may be federal requirements. Generally speaking, that comes from if you participate in a federal program or if you participate in Medicaid, for example, there are required services, optional services. Same thing with certain types of federal grants. You mentioned legal services and things like that, where typically that funding comes from Older Americans Act dollars, which are federal, and then there are requirements if the state participates or receives those grant dollars. So it's kind of a mixed bag on federal requirements, and can absolutely generate a lot of discussion about what is quote unquote required versus optional for the state.
Thank you. Let's kind of plan it as you described. For example, we start with aging, hit some of the highlights for us, and then I'd like to pause and allow anybody on the committee to ask a question under that section. And then once we've closed that out, move on to behavioral health, et cetera. And I think we can move rather quickly through this.
You bet, Mr. Chairman. So just by way of introduction, talk about a little bit of what HealthStat is. So this was an initiative that began in around 2011. The director of the Department of Health at the time was Director Tom Forsland, and he had a lot of experience managing the city of Casper as its city manager for over 20 years. And had some success with what are generally called in the academic literature performance stat programs. This really kind of didn't necessarily originate, but really stemmed from scholarship from Bob Bain, who was a Harvard Kennedy School, JFK School of Government professor, and developed some frameworks for performance stat programs. Some of you might know that, going back several decades ago, there were law enforcement entities like the New York City Police Department that also experimented with performance at different ways of quantifying not only what you do, services you provide or things that you buy or things that you produce, but what you're trying to do. So outcomes that you're trying to generate, and what data do you have, what measurement do you have that can point you in the direction of, are you achieving the outcome that you're looking for? So performance stat type programs are not something the Department of Health invented, but we've kind of blended a lot of over the years, a lot of kind of academic frameworks and performance management, performance stat frameworks to customize our own performance management system that we call Health Stat. And like I said, it was implemented in the Department of Health, or began in around 2011. I came to the agency about 2 years later in 2013. So we were kind of in our infancy in Health Stat, but something that we have absolutely kept going in the Department of Health and really grown and evolved over the years. Before going too deep into the introduction, I just wanted to mention that this is a couple of different things that we've been trying to achieve. One is to, at a higher level, kind of at a leadership level, be able to discuss and describe our programs using similar language. The Department of Health is really big, as you know. We have, 4 operating divisions, plus the director's office, 5 direct care facilities, numerous field offices in your communities around the state. And all of those programs, services, populations that we serve are very unique, different in the things that we're doing. But one of the big objectives of Health Stat is, can we, more for a lay person or even leadership in the department, describe the functions of a program, its money, its people, what it's buying, what it's producing, and what it's trying to achieve in a similar framework, in a similar language. So across the Health Stat documents that you see, which are really our year-end reports that we always send to the governor and the legislature annually, generally in February of each year, we will send the most recent reports to the Appropriations Committee, the Labor Health Committee, and the governor. You'll see a similar framework for each function or each program, and that is a snapshot document, which really describes just kind of the overarching information for that particular program. It's 3 fiscal years of cost, for example. It's total program cost, the number of people that program serves, the cost of that program per person based on the number of people it serves. Information like how much of the program costs are what we call non-600 series, or essentially things that are contracted out or require staff, 100 series salaries or admin support. So you see just kind of some helpful information, some bullet points in the program snapshot document, and also some cost notes.
Director, if I may, you made a comment about trying to make this more clear for the layperson and about terminology having to vary. That's been one of my personal frustrations, is it may be the same program or we may be talking about the same thing, but the terminology has a tendency to vary a little bit. And I'll give you one quick example and possibly a suggestion for something that might help make the Health Stat even more clear. It is an exceptional piece of work, and I found it very useful. But for example, when I got it, I went back to the very first meeting that we had, where we went through basically all the agencies and a description of what they did, and we did it by line numbers, whether it be the 500 series and all those. If that could somehow be added to this, just to make sure that we're looking at the same thing, is I get the feeling that maybe some of these are kind of a summary of 2 or 3 of those things. It's really hard to figure out exactly what we're talking about too specific so that all the numbers add up. So that's just my plea from here.
Well, and Mr. Chairman, it's a good plea, and I'll answer your challenge with another challenge that we have. We've tried to organize Health Stat over the years in discernible, programs or functions. But that doesn't always, to your point, that doesn't always port over directly to the budget book, for example, because you have budget units that encompass, in some cases, 8, 9, or 10 different programs. And so it's been a challenge over the years to think of the best way to do that. But keep in mind that we use Health Stat as an internal performance management tool, as well as an external performance management communication to decision makers. So I'll get into some of that, but your point is very well taken, and I'll just be open and transparent that all models are bad and some are better than others, or some are helpful, and so there's certainly pros and cons to that. But it's something we have struggled with over the years, of even determining what is a Department of Health program. Is it something that's specifically in the budget? Is it something that we have money and staff going towards? Is it something that has a name? It really does vary. So your point's well taken.
Yeah, thank you. And I do understand the difficulty in that. It just, when you're coming from the outside and have a limited amount of time as we've had in this committee to be able to get a grasp on it is that's an exceptional challenge. But anyway, I'll step out of the way and let you continue.
Well, Mr. Chairman, to that point, what I think from an external audience, whether it's the governor's office, the legislature, or the public, what we hope the health stat document is helpful, because it is a long document. What we hope it's most helpful for is really a reference point that if you are considering, a budget request or a bill that involves a certain program, is there something that you could go to? And this document's electronic. You can click on the table of contents and you can pull up a specific program in a specific division, and again, get some high level performance data. I have to be clear that, because my staff would mutiny if I didn't say this, that obviously within a program function, there's tons more work and data and measurement that's underneath and in support of the overall health stat document. But the task that we have every year is how do we communicate the problem that we're trying to solve with a program function? And I'll get into how we structured that. And then at the highest level, how much money are you spending? How much staff do you have? What's your basic value chain of inputs and outputs and efficiencies? But ultimately, how do those all lead up to the 3, 4, or 5 highest level outcomes that you're trying to influence for that population or for that community or for that specific function? And as you see through the health stat documents, it's a mixed bag, not only in terms of overall performance, but also in how that's communicated. But just very briefly, Mr. Chairman, over the years, starting in 2011, the legislature liked health stat so much at that time that they actually codified health stat into statute. And so, before even your time as legislators on this committee and your other committees, there was a time when the Department of Health had dozens and dozens and dozens of legislatively, statutorily required annual reports. Some of those topics were very esoteric. Some of them were in session law when the legislature passed something back in the early 2000s and said the Department of Health shall produce a report on this particular topic, October 1st of every year, and send it to the Labor Health Committee or send it to the Appropriations Committee. When we really started to hit our stride with health stat and really have this sort of Bible of performance management data across these functions, there was a big efficiency the legislature identified, which was, hey, we can just reference some of these performance data, these performance reports, in lieu of having, executive branch staff working for a couple of months to produce a specific report. And so around that time, I believe it's in Title IX, yes, 92102O, the legislature codified the department shall provide to the Joint Labor, Health, and Social Services Interim Committee and any other appropriate legislative committee periodic reports from the department's internal performance measurement system. And they're referencing health stat there. So again, as I mentioned, every winter, right around the time that the legislature is convening, we send the updated health stat reports to the governor, to the Appropriations Committee, to the Labor Health Committee, and frankly, from my perspective, anybody else who would be interested in reading our performance management data, we're happy to send that to. So kind of talking about what is performance management, we've summed it up. It's kind of a kitschy little phrase, but this is how we communicate to our staff, is really what we're trying to do in health stat, in the Department of Health internally. We're trying through this approach is to figure out what counts. So what are our department's priorities? What are we promising, or what are we directed to do for Wyoming residents, generally through statute, through law that says, Department of Health, you shall do this thing, and here's an appropriation, or here's staff to do that thing. And also what our programs actually do. So in a very kind of blunt way, what are you buying? What are you producing? What are you serving? Who are you serving? And so that's really where we say, figure out what counts. What are we trying to accomplish? The second step is to count it. And that's easier said than done because quantifying health and human services can be inordinately challenging. But really what we're trying to direct our program managers and our staff in the department to do is develop measures that answer the question, how are we doing? So step one, we figure out what counts. Step two, we count it. And step three is really about accountability. So we're really promoting the use of data-driven decision making because it's one thing, and we have a lot of very experienced and expert staff in the Department of Health, as most state agencies or large organizations do. And you definitely want to trust those experts and experienced staff. But we also want to be able to quantify those things. So if you're buying something, how much are you spending? How many units are you procuring? What are your outputs there? And how much input, money, staff, et cetera, did it take to generate that output so that we can measure some efficiencies, right? How good are we at just the nuts and bolts of procuring a service, procuring a product, or producing it or delivering it ourselves? And really within that accountability framework, determining the effectiveness of program activities and their current strategies. And I want to linger there a little bit because it's one thing to have this framework and, hey, fill out this form and put the numbers in. But over the years, especially since I've been here, one of the biggest efforts has been developing a culture of performance. And I'll hit a few highlights there because I do think it's important, especially for an organization as large as mine, that again, the framework doesn't drive the actual performance. And we've experienced this too, that you can do data analysis and program management for the sake of data analysis and program management. Okay, I've got to come in front of the director this year as a program manager and present my health stat information. What you don't want is for that to be, okay, let me spend an hour, do a dog and pony show, say everything's great, and then move on, and maybe I get called back next year, maybe I don't. But what we're really trying to promote is a culture of wanting to see, improvement, continual improvement. And what that kind of needs at a baseline or a bedrock is you have to have those program managers, leadership in your agency, and your staff, your experts, comfortable coming into a setting like that and pointing out where things are not working. And that is easier said than done because in many performance management systems or performance stat frameworks, often folks can feel like this is a personnel issue, right? If I don't say that my program is doing a wonderful job and there's no issues, I might face discipline, I might face termination, et cetera. And we've really tried to back that out of this whole framework. And I'm proud of especially the last 2 or 3 years, where I think we're much further along the continuum of a agency that has a culture of performance, where I'm seeing much more of our staff coming in and saying, okay, yes, we do a great job, we work hard, but we are just missing the mark on this outcome. And then we want their feedback. We want their expertise. Why are we missing the mark? Is that a money issue? Is that a staff issue? Is that a statute issue? Is that a rule issue, a policy issue, a contract issue? Where do you need help? Or should we not be doing that anymore? Is that an endeavor that we can't solve for that problem and we should pivot those resources to other things? So that accountability piece is much less about on the personnel side or the discipline side, and much more about we are given public resources by the legislature and we're given a task to solve X, Y, or Z problem. How are we doing that? And having a way, kind of in a transparent framework, to show yes or no, or it's complicated, of are we moving towards that overall goal. So as I mentioned, we promote or produce these annual health stat reports. You've seen that. You've seen the most recent iteration. We'll go through some of those today. But in addition, give you a sense of the process internal to the Department of Health. So except for the weeks of the legislative session, we do health stat performance management meetings every other Thursday in the department. And I have a leadership team that consists of my senior administrators, including our CFO, our deputy director, our kind of business office administrator, as well as a few folks from each division that are kind of tapped into that health stat leadership team. And we structure them pretty formally. In fact, this year we experimented with a legislative style structure where we did full Robert's Rules of Order, kind of assume you're in front of a legislative committee. And I really liked that format because it helps us grow the bench of folks doing public presentation, public speaking. So there's a professional development aspect to HealthStat as well, being able to present publicly, speak publicly, but also keep a tight presentation within an hour where you're really trying to pull a thread of here's the problem we're trying to solve, here's our big performance deficit this year, and here's what we would like to do about it or what we're proposing. But also that regularity of HealthStat where we select, programs every year to come do these presentations, I think keeps a little bit of standardization around. We will continuously and for years, certainly as long as I'm here, be doing HealthStat during those weeks and months outside of the legislative session. Like I mentioned, Mr. Chairman, each one of our program functions has the snapshot document, but most importantly has the performance report. So every program has those two documents, and some of our challenges year over year are trying to determine and making sure, do we have the right information in there? Have we selected the right outcome measures? Have we selected the right output or efficiency measures? And those can change year to year. So I want to be clear with the committee that what you generally see in HealthStat is at least the most recent 3 fiscal years of data. We obviously, as data nerds around here, we want as many years as data as possible to really measure longitudinally how we're doing. And it's important to reiterate here that behind HealthStat, underneath HealthStat, numerous ways that we track data. So what you don't see here is all of the Medicaid data we have across the department, claims data, provider enrollment data, outcomes data. A lot of that is in HealthStat, but it's really a higher level kind of summation of these different program functions. But I'll take we'll start with the aging division. I'll take a few examples just to walk you through snapshot documents and performance report documents. Starting on page 35 in the aging division, this is our Wyoming Home Services program. And I selected this because this is a state general fund program. It's been discussed, as Representative Sherwood will remember, many years at the Joint Appropriations Committee of, are we achieving the goal here, and should we be doing this? It's a state general fund only program, relatively small compared to our Medicaid long-term care programs at about $5 million a biennium, $2.5 million a year. But I'll take that as a first example, number one, just to walk you through the layout of HealthStat, and then number two, maybe show you some interesting challenges that we deal with in quantifying performance management, some of the questions that come up internally in the department. But on page 35, you'll see the snapshot document. It starts with a brief program description, what the program is. Generally speaking, you'll see notes here about where is its statutory authorization, but mostly a couple of layperson sentences on just what is this. The next table just shows you the program expenditures and people served. So you see the last 3 years of total program cost. The next line is the number of people served, and that can vary across the type of program that you have. In a population health program, you might see the entire population of the state there because that's essentially who's being targeted, and that gets difficult in determining the cost per person. But in this case, we have specific enrollment for Wyoming Home Services, which is a program that's largely run through senior centers. It provides kind of on the non-Medicaid end, so it's not a Medicaid program, but it provides some home care, home health, personal assistance for folks who are aging, and contact the senior center with certain assistance that they're looking for, and that can range from some light house cleaning, even light yard work, taking out the trash, to more intensive and more clinical services like personal care in the home. So think of activities of daily living like toileting, bathing, things that you would kind of consider home health or home health related. And again, relatively small program, serves about any given year about 1,500 people. And you can see our non-600 series costs there are quite low. Almost all of this, about 99% of the dollars in this program really go to support those senior centers that are delivering the home services. Mr. Chairman, I'll stop there. I see that you have your hand up.
Thank you. One of the things that I appreciated about how this health stat is laid out is it talks about funding. State funded grants, 70% roughly, local 20%. And it says 8% program income. Could you describe that briefly? And then also Title 3B had some program income, just a very brief direction as to what that stands for there.
You bet, Mr. Chairman. So in this particular program, and again, you'll see similar cost notes across a lot of Department of Health programs. So this particular program, yes, it has kind of a 70% state cost. We do require kind of local contributions, generally from the senior center. That can be, local match or county funds in some cases, kind of a blend there. And then program income in this program, and this Representative Sherwood might mention this, the JAC and legislature directed us several years ago to do a couple of things. One was to means test this program, which we implemented. And the second was to essentially collect contributions from the clients. And that's on a sliding fee scale in this program. So the program income has a couple of different avenues. One is just what I mentioned, where we do collect some, it's small, but some revenue from the participants themselves. And while we don't want to, turn folks away, so I mentioned the sliding fee scale, we essentially, those providers and senior centers determine what can that participant contribute to the cost of this program. Secondly, there's program income or revenue, and Eric could get into some of the esoteric details if you'd like here. From time to time, we do have grant funding from, in this case, Title 3B, which is a federal Older Americans Act grant that can be used to supplement programs like this. So in certain years where we're directed to reduce general fund, or in periods where, in some cases the local match was unable to be generated, and we have the ability to backfill that with federal funds, we can do that from time to time. But the basic program cost structure here is through an appropriation from the legislature of about $5 million on the biennium, and that's really what constitutes the bulk of the costs. Eric, anything you want to add there?
Mr. Chairman, members of the committee, thank you, Director. Yeah, I think just what the director said. Occasionally, we can reach out to our federal partners if there's been a change in income or in our ability to pay, like say the counties, and see if our federal partners are okay with us using some Title 3B funding for those type of things. So it's unusual. It's not like we can supplement a lot of funding from our federal partners, but in extreme cases, we can reach out and sometimes they will approve those things. Thank you.
Thank you. That's helpful.
Mr. Chairman, if you'll turn to page 36 of that document, again, kind of in the spirit of this presentation, I'll give you a general overview of what these performance reports looks like. So we went over the snapshot, and that's just kind of the bare bones basics of the program. And then we get into every program having a performance report, which is laid out in a similar framework across all of these programs. But I want to spend a little bit of time on a few of these sections. And the first is program core purpose. This is both a passion and a challenge of mine, because one of the most important things, and it sounds really oversimplified and silly, but one of the most important things you need to do in performance management is have a very concise statement of what that program or function is trying to accomplish. And you have no idea, Mr. Chairman and members of the committee, how difficult it was, 10, 15 years ago, just to get the program core purposes established. As you can imagine, folks who do this work and work in these areas day to day, they want to communicate and tell everybody in the world of what's going on in that program, because there's a lot of nuance, there's a lot of complicating factors, there's a lot of federal regs, state law, licensing and survey, those types of things in health and human services. And this is an inordinately challenging for us to say, no, we need a sentence or two. What are you trying to accomplish in this program? So I would just point the committee in the direction on each of these performance reports to pay attention to the core purpose, all of which are debatable. We're always open to feedback on, how should that be structured? What is this program actually trying to accomplish? But over the years, we've gotten a little bit better at setting what that is, because it really then does govern and dictate what does the rest of the report look like? And honestly, when you can simplify into a sentence or two what you're trying to achieve, then suddenly that value chain of what you need to measure and what you need to collect becomes a little bit more illuminated. And I remember when we were kind of growing and establishing HealthStat, there was an extractive industry probably decades ago that was also going through similar performance management. We're going to do this sort of performance stat thing. And it was a coal company who developed a core purpose, and it was one sentence with 3 words: we dig coal. And I always loved that because it was so simple to say, what are you trying to accomplish? Well, we're digging this stuff out of the ground, and our measurements are all going to be related to that. And so the simpler these explanations are, the better, noting that it is very difficult in some cases to capture all of the nuance and complexity of a program in 1 or 2 sentences. But in this case, in Wyoming Home Services, what we're trying to accomplish, the program's core purpose is to serve senior citizens and disabled adults to prevent the premature institutionalization or inappropriate institutionalization. And what that means is we're trying to prevent or delay long-term care facility admission, plain and simple. We are trying to serve these folks in their home setting to prevent them going to a higher level of care like a nursing home. And Mr. Chairman, I see you have your hand up. I'll stop there.
Thank you. Is there a library of past editions of this? And the reason that I ask is you watch these core purposes, and I'm sure that they're fluid. As the needs of the public change, the core purpose will change. But I also see perhaps, let me just jump ahead for a second. Chronic disease prevention. When that first started, it was probably pretty limited to certain things. And then recently, okay, now we decided that obesity is a chronic disease, so we're going to add that. And it would be interesting to go back and kind of get an idea of how these programs have morphed over the years. So is there a library there?
Mr. Chairman, absolutely. I believe we have annual HealthStat reports going back to 2012 or 2013. In its first year or two, again, it was just kind of developing. We started, and I came to the agency in 2013, and our unit here in the director's office really started formalizing and producing these annual reports. At the very least, going back to 2015 when the legislature codified it in statute. More than happy to send all of those reports to the committee. We typically, Mr. Chairman, if you go to our website, we post the most recent version of the HealthStat reports. But you bring up an important point because things do change and evolve over time. Generally speaking, you mentioned an example that's kind of an exception to the rule. Generally speaking, you'll see relatively static program core purpose unless something major has shifted. So unless the legislature has changed a law, or in some cases eliminated a program, or fundamentally changed the direction of what the Department of Health shall do or what's been appropriated, those cases will drive a change to program core purpose or even some of the measurements that you see in the documents. But generally speaking, they're relatively static over time with some of those meaningful exceptions.
Thank you.
So going into kind of the document itself, we start with what is most important. So program core purpose, what are you trying to achieve? The first table that you see there are the outcomes that the program has selected that we measure at a macro level year over year. And in many cases across these programs, again, as I mentioned, much more granular data underneath HealthStat where we have month to month or even week to week. And in the case of Medicaid data, we can go day to day on data. So much more granular data behind these. But for communication purposes, we task our programs, again, not easy, just like the program core purpose. What are you going to select? We're limiting you to 5 here. You can't give us a report that has 27 outcomes on it. We're not going to give that to decision makers. We need to roll that up into what are the most important outcome measures that really nest and tie back into that program core purpose of what we're trying to achieve. And so here, in the handful of outcome measures you see here, the first 2 are related to what we call activities of daily living or instrumental activities of daily living. And you can see that what we're measuring here is the percent of program participants with essentially an ADL, Activities of Daily Living score of 2 or higher. And what that's gearing at is we want the program to try to target those most in need. That also comes with a downside. You don't want people to have multiple challenges with their activities of daily living. So we're not trying to encourage, folks having issues, but we're trying to have the program's administration focus and the providers focus on targeting the folks that are most in need, given that we always operate in budget constrained environments, so we have to prioritize. And the second outcome there, instrumental activities of daily living, or IADLs, that's a more granular measurement. Typically, if you are higher on those, it kind of means you're starting the process of having those more major activities of daily living challenges, things like bathing, toileting, feeding yourself. Instrumental activities of daily living are kind of a proxy measure for that on, how are you ambulating, or are you starting to have falls or balance issues, things like that. But all of these outcome measures, you can see we set a fiscal year target. And then in the right side of that table, you can see year over year how that measurement came in. Are we meeting that target? Are we exceeding that target? Or are we under that target? And in this case, you can see we're under the target in the first measurement, and we're closer to the second measurement target. So it informs policy decisions. It informs things that I might authorize on what can we change with our senior center contracts if we want to increase this. But we really want to, try to see that trending over time. And with these particular measures, there's a lot of conclusions you could draw. And it's very hard always to get to the exact 100% truth. But we know that Wyoming's population is rapidly aging. We also know that the years of the pandemic, especially with folks more susceptible to infectious disease, we had major changes and challenges with delivering certain types of services. And so you can see this particular outcome measure dropping. The third outcome measure is, how many people do we have on the wait list? We know that in many of these programs, demand outstrips supply or outstrips our budget. And so we've set a conservative target that we'd like to try to manage as close as possible to a wait list no more than 100. But you can see we hit that in the fiscal year prior to the most recent. In fiscal year 23, we were under 100 people, and that has grown. And you can imagine our program leadership and the folks that work in this and our providers that deliver the services can be irritated with me of saying, well, we don't want to show bad performance. We don't really control that, right? If more people apply or more people come in and we don't have the budget or the personnel, you don't give us the money to serve them, then we just can't serve them. But again, I think it's important for us as decision makers in the health department, for you as decision makers in the legislature, to at least be able to quantify those things, good, bad, or indifferent, and say, okay, in this particular program, the department is seeing slightly higher, it's not exorbitant, but slightly higher demand than the number of slots that we're able to serve through this program. The last two measurements, Mr. Chairman, they're a little more technical around the types of participants that we're targeting. And this really goes back to discussions at JAC we had several years ago, when quite frankly, this program was being discussed as a potential elimination during the budget cuts. And in fact, in one of the budget cut proposals, we had actually put this program to be eliminated in one of our, I believe it was the step 3 budget cut reductions, which the legislature, the JAC and the legislature did not accept. They essentially restored the funding for this program. It's not something that we recommended positively to say, hey, the performance of this program is no good. We should cut this program. It's not achieving its purpose. But the reason for that recommendation on cutting it was it's general fund only. It's a relative to some of our other safety net programs, a smaller amount of participants, really a tough decision, something we didn't want to recommend, but we were forced at that time to say, if we have to hit that budget cut target, this would be one of them. And so the JAC and the legislature at the time, as I mentioned before, directed a few things. Department, you should means test this program. Let's see if there are folks that are of more means that could be financing their own care and shouldn't be on a state generally fund only program. So we implemented that means testing, assessing people's income, and really found that the vast majority, in fact, well over 90%, were under 200% of the poverty level, and or thereabouts. And so you see two measurements here of kind of contribution level of these participants and where they fall in the income spectrum. And I think the data there show you that, generally speaking, the folks that are reaching out to this program or these senior centers for this particular type of service are definitely of less means. Fundamentally, as you see in the program core purpose, this, I think, it jives or works in conjunction with a program you'd see later in the document in our Medicaid section, which you're probably well familiar with, which is a similar type of mission, but it's a Medicaid waiver. We used to call it the long-term care waiver. Now it's called the community choices waiver, where folks who are eligible for Medicaid nursing home placement can elect to have home and community-based services instead. Very similar to our developmental disabilities waiver, but really targeted towards the elderly population or the disabled population. And this program in many of your communities, many of your senior centers, really works as a pre-Medicaid, prevention measure. So folks come into the senior center maybe for a meal, which the senior center provides, congregate meal or an activity, and they say, hey, you might be able to benefit from this program. Or the client says, have a meal, what else do you have? And you can see we want to prevent a trajectory where your condition worsens and your only option would be a nursing home, which is very costly to the state. Let's provide some services maybe in your home or some light assistance before you even think about a Medicaid application or a waiver application. Let's serve you in this smaller program instead. Mr. Chairman, at the bottom of page 36 and going into page 37, and again, this is for all of our programs, you get a little more nuts and bolts of the outputs. So in these tables, you'll see number of people served. You'll see things like the number of service units provided in any given year. And in some cases, we have it broken out by quarter for the most recent year. So services, units of service, and as a recovering economist, I'll mention this is kind of where we get into what widgets are you producing? What are you buying? What are you delivering? It's not an outcome measure, but it's just what's going out the door in terms of actual units of service or things that you're producing or buying. And the last table is kind of within that value chain of efficiencies. So what's the average cost per person? What's the cost per that unit of service based on what we reimburse or based on what we budget? And you can see that broken out here in a couple of measures. So the average cost per person in this program is generally around $1,700–1,800 per person. The average state cost, so we only use the state general funds here. And Mr. Chairman, you mentioned there's other funding sources that support programs like this, like local match, client revenue, some of those things. But we want to look at what's the state putting into this. So the average cost per unit of service in this program is about $37 in the most recent fiscal year. And the average annual cost of service for each participant in terms of the program income is around $200. So again, that gives you a sense, Mr. Chairman, of how we structure all of these performance reports. And you'll see a lot of variability here in the types of information, the types of outcomes that are selected depending on the program. But what we really want in the department is, in general, in a macro framework, to have the same basic layout. So we want a snapshot, give us the basics. And then when you move to the performance of the program, we want a concise, clean core purpose. We want a limited table of your highest level, most important outcome measures. And then we want your value chain, your outputs, your efficiencies. And so that gives you an overview of one of the programs in our aging division and how we structure these health stat documents. Mr. Chairman, within the aging division, happy to go into some more detail on some others or answer questions, but thought given the length and breadth of this document, I picked one or two in each division just to give you a sense of some of the successes we see, some of the really positive trends, but also I have some examples as we go through these of areas where we really struggle, and we have some tough questions on are we doing well here? But also, should we keep trying on this? Should we try a different approach? Should we try a statute change, a rule change, a money change? And we'll get to some of those examples as well.
I think that's a good plan, and I personally don't have any more questions on aging. We'll check with the committee here in a second. Bear in mind, committee, we're going to be having some work day or some time in the future where we can sit down and work through these things. And I think a lot of the questions that I have specifically flagged here would come out at that point. So I look forward to that. But any other questions on the aging department from the committee? Everybody's happy? I was kind of curious because you said that Wyoming is rapidly aging, and yes, I knew what you meant. But if you believe in the theory of relativity, we're all aging at the same rate.
Mr. Chairman, that is absolutely true. But the demographic data does not lie. Relative to other states, we are one of the front runners in terms of our demographics, which again you'll see throughout some of our programs and health stat documents. Absolutely has an influence on the volume we're seeing in enrollment or wait lists. But yeah, it's I'm aging at the exact same rate that you are, sir.
Problem is, I'm a little closer to the end, so I'm more acutely aware. Let's see, move on to behavioral health, if you would, sir.
Absolutely, Mr. Chairman. So we'll flip to page 48, just selected. There's a lot of programming in behavioral health division, but fewer functions. So as you'll recall, in our behavioral health division, we have mental health and substance abuse, which is all of the funding for our community mental health and substance abuse centers. We have early education, early intervention and education, or our developmental preschools. And we have the Wyoming State Hospital and the Wyoming Life Resource Center. So fewer overall functions, but a lot of funding and a lot of programming in this division. What I've selected to go through here in terms of the snapshot and performance report is mental health outpatient. So again, this is funding that flows to your community mental health centers around the state to provide outpatient mental health services to certain populations, which I'll get into here in a bit. But you'll see on the snapshot, page 48 of the document, we have our mental health outpatient treatment program, and the program description, again, pretty simple, provides access to effective outpatient treatment services to improve the levels of functioning for persons with mental illness. Program cost in this area on an annual basis is around $16.5 million. So you can, all of those fiscal year or annual figures, you can double those to get a sense of the biennial budget or expenditures. I'll mention here that the 4 units that are mental health and substance abuse, mental health outpatient, mental health residential, substance abuse outpatient, and substance abuse residential, these are examples, Mr. Chairman, of where the program documents in health stat absolutely port directly over to the budget units, because we have 4 budget units specific to this area, which is very clean, cut and dry. But still, as you can imagine, there's discrepancies between what you see in the budget book, which is really from a budgeting standpoint, and what you see in health stat, which is service delivery and cost. So you see here expenditures, not total budget, if that makes sense. But the information, the function itself is more of a one-to-one in what you can compare with the budget book and the health stat performance reports.
So that does lead me to a question. It's probably a real simple answer, but looking through this, I noticed early intervention, Part B, Part C, and that accounts for 22 and 931. But the budget roadmap, that was another document given to us, talks about almost $93 million. So what am I missing? I see there's a Part B and a Part C. Is there a Part A that's not included here, or how is that calculated? If you could help me out.
Mr. Chairman, a good question. Two things that I'll mention. One, again, with the health stat documents, you're looking at actual expenditures, whereas in the budget book or the budget roadmap, you're looking at overall budget. So there's often going to be, discrepancies there, because in some biennial or some fiscal years, we have generated reversions where that amount of money is not needed to be spent. In this case, you can have discrepancies because the number of children identified as being eligible dropped in a particular year. And we've seen that in some of these programs over the years, where the number of children, in some cases, in some years, grows. And so that cost will go up. In some cases, it drops and that cost will go down. The second thing I'll mention is that there are other, within the budget unit for EIEP, I believe that's unit 2510, Eric? No, yeah, that's right. There's other programs, smaller programs, like we have a hearing program that supports the developmental preschool children, but it's specific to hearing assistance. That's not subsumed within the program function directly for the special education and support services for the kids. So again, really good question. It's Mr. Chairman, just take some liberties here. It's a fundamental challenge we've had, and we could use the budget book to say that's going to govern health stat, but then you have also the budget book is a very macro document, and we lose functionality within that. So we've gone back and forth over the years, and I was going to get to this later, but I'll mention it now. You'll see several functions of the Department of Health that are not in the health stat reports. For example, all 5 of our facilities are not in the reports that you see. Just in the last 2 years, we have incorporated the facilities into our internal health stat process, multiple presentations from our state hospital administrator, life resource administrator, and really good data analysis exercises that were done in those health stat meetings and presentations. But over the years, we've had kind of different performance reports for our 24/7 facilities, different iterations of that, and we just have not put it into the health stat binder yet. We're working on formatting that and coming up with a process to do that. And another example is our vital statistics office, which exists in the director's office, does all of your marriage, death, birth certificates, abortion reports, those types of things. And we just had our first inaugural health stat presentation and snapshot and performance report document for vital statistics developed this year. So we plan to add that to our health stat reports for the next iteration. But there's a few things that you'll absolutely notice. Where is this function? And part of that is kind of the evolution of health stat as an institution in the Department of Health, that there are things that are in here that you might not know existed in the Department of Health. There are also things that you might see in the budget document that don't exist in health stat, and you might wonder why. So just a few things I wanted to point out there.
Thank you.
So going through it won't linger too much here. You can see the total program costs in mental health outpatient. The total people served, you can see a significant drop going to fiscal year 24. A couple of reasons for that. Some of it is just volume and demand from the communities. We know that the mental health provider landscape, just in the general economy, has grown wildly over the last 10 or 15 years. And so many folks might not be seeking services at their community mental health centers, and instead using private providers, or insurance coverage has largely grown to cover certain mental health and substance abuse services, especially on an outpatient basis. So you have more non-state payers for those types of services, especially over the last 10, 20 years, that market has really grown. Secondly, as you all are aware, we've over the last 5 years or so, we underwent a significant reform to our community mental health and substance abuse system, what we call the behavioral health redesign. And that took effect July 1st of 2024, where the legislature through statute and the Department of Health through policy, we really prioritized the type of folks that were eligible for community mental health services, to include some of the populations we were talking about earlier this morning. Acute psychiatric individuals that might be in the Title 25 or adjacent to the Title 25 system. Criminal justice involved clients, either in Title VII or in your local jails, committing crimes or what have you. That's a priority population. High needs children and their families, either in the DFS system or at risk of going into the DFS system. We've really, in a conservative way, prioritized what this funding goes towards. So you will see a total enrollment drop because we've organized this funding around a smaller subset of higher needs individuals over time. So again, just giving you some impressionistic senses of why you would see numbers drop. And again, the point of this presentation and going through some of these performance reports is to give the subcommittee a sense of what do I use? What does Department of Health leadership use to actually manage the enterprise? And in many cases, these types of reports and the data that support it are absolutely the information we use. You can see in the non-600 series, this is a very administratively lean program. So around 99% of these dollars go out the door in contractual payments to our mental health centers. But I don't want to brag too much about that because, as you all, as appropriators, know, every one of our divisions has an administrative unit in the budget book. So most of our staff costs are not in this budget unit, but in 2501 Behavioral Health Division Administration. So that's where most of the administrative costs for the program operations are kind of subsumed within. But you can see within the program function, a light amount of administrative costs, more geared towards systems, data systems we have to not only monitor and measure what services are being delivered, but making payments, some contractual services that we might incur from time to time. But wanted to make sure I pointed that out. If you flip to page 50, you'll see the performance report for mental health outpatient. And two of the outcome measures that I wanted to mention start with the first one. So access to care, average days from the time of first contact to the first treatment service. This is something that we've really struggled with measuring over the years, and also really want to give a sense of the honest performance of these programs. This is a tough population to serve, and you get a lot of no-shows. You get a lot of people who don't show up, but especially in how we've reformed and really targeting a higher needs clientele over the years, we want to make sure that our centers are, when there's someone who's referred or signs up for treatment or gets discharged from the state hospital and needs community mental health center support, that when they make contact, we kind of want to measure and have them report not just that someone's made contact, but how long does it take to get them into their first appointment. You can see the performance looks good here. It's relatively low. When I see really, really low numbers here of, okay, we want to be under 7 days from the time someone reaches out to their first appointment, I get skeptical. And so we've actually done a deep dive in this to see, what are we missing here? Are there data elements that aren't being reported, or are there folks that are being lost in that measurement? Because when it looks that good, you can probably assume that there's something missing. So I don't have an answer for you yet. It's something that we looked at just this year in HealthStat. But I do think, on the other side of that coin, by and large, through the behavioral health redesign and the partnership with our community mental health centers, and sort of that relative shrinking of that population to prioritize those most in need, we have seen a dramatic improvement of folks that are getting in quicker. That's not always the same for a residential bed because supply is really limited there around the state. So you could have, days, weeks, and even months to see a residential bed open up. But this is both, again, it's one of those performance measures that you say, that's very heartening. We're doing a really good job. But also skepticism of, what are we missing there? Is that entirely accurate? But a general sense of, I think we have absolutely dropped and been moving in a good direction. But a deep dive is always needed to say, what's generating that really good outcome measure that we're seeing there. The second outcome is the last one that I'll mention. And this is something that's relatively new. So you'll see a lot of non-applicables in the previous fiscal years. But really looking at the percent of clients with an improvement in what we call their daily living activities. Very similar to what we talked about in the Wyoming Home Services Program, but more geared toward behavioral health. Do we see an improvement in score of how they're doing in their essential day-to-day functioning? And it's something that we just recently started to measure, and obviously we want that to greatly increase. So you see, starting in fiscal year 23, pretty low, under 7%, but a marked improvement, which has a lot to do with data measurement and data integrity and quality. When you start measuring something and collecting those data, that's being reported to us, you'll see a gradual improvement. But something that, again, philosophically, we want to not only know how are we doing at delivering the service and what it's costing and the efficiency of it, but are people getting better? There's ancillary measures here with community mental health and substance abuse that we also look at outside of these performance reports of that is also a part of the system, like our staffing costs that we talked about earlier, the number of beds we have available. This is directly related to state hospital wait list. Can we discharge more people out of the state hospital to community supports and therefore free up beds? So we've really started to look at mental health in this lens as a continuum that includes state facilities, corrections, courts, and our programming like this that are all geared at supporting, the same kind of people and the same kinds of problems. I'll just reiterate, if you go down to your outputs in the number of people served, you can again see a gradual decrease over time. And that can be alarming to some folks that would look at that and say, wait, we're not serving as many people, therefore our cost per person went up. But keep in mind, we've also fundamentally reformed what these dollars go to and who they support. It's much less now, starting July 1st of 2024, much less general access, where come one, come all, sliding fee scale. This program is very prioritized to those most in need. And that's a relatively recent change. So the drop in total enrollment or people served does not surprise me. And in fact, can be a great benefit where we're essentially using the same amount of resource to support a higher needs population that we hope to generate better outcomes for. Mr. Chairman, on behavioral health, I think it's a good example of the types of things we measure, also the challenges of measuring it, but I'll stop there, see if there's any questions.
I did have one. I did have one. I'll start with that. Down in the benefits section, there's a behavioral self services, and I found something very interesting there. This is a significant law passed in 2021 by the Wyoming legislature. Supported efforts to strengthen Wyoming's behavioral health system. The chief goal is focusing state resources on those who need them most: acute psychiatric adults, criminal justice involved clients, high needs children and families, low income and indigent general access populations. I like that idea because it helps you, like your core purpose, helps you focus on what you're at. And my question, and maybe there's an answer and maybe there isn't, is there somewhere an overarching similar list of where the Department of Health's focus is, a kind of a hierarchy of needs, or these are the most critical things, and then these things we're going to do if we possibly can? Is there any kind of a statement like that?
Yeah, Mr. Chairman, great question. So what I would point the subcommittee to is, and I'm going to sound like a card-carrying bureaucrat here, but it's true. I would point to our agency level strategic plan, which, as we talked about in our first meeting in Casper, and I believe we provided that to the committee. If not, happy to send it. We just redid that strategic plan about 2 years ago. And I think that's what you're getting at, Mr. Chairman, is I really tried to focus the agency in that strategic plan document on what is most important, core and safety net. Obviously, you can look at large organization strategic plans, like the Department of Health's previous strategic plan. Very good document, about 100, almost 100 pages. There's a lot in there. What we know is that over time, you look at the things we said we were doing in that strategic plan, the things that weren't funded, that weren't prioritized, that weren't staffed, that the legislature didn't prioritize or cut. You can see we didn't achieve any of those, strategic priorities. But the ones that we really, at our facilities, for example, at our field offices in public health nursing, in Medicaid with our core services that we deliver for the aged, blind, disabled, all of those things that were, represent the bulk of the department funding, bulk of department staffing. We were very good on the performance of those in the previous strategic plan. So we reoriented the department's plan around that concept of what is core, what is critical. And I appreciate you raising the issue, Mr. Chairman, because kind of the philosophy behind HealthStat is really nesting within that hierarchy. So the Department of Health strategic plan is the macro document that governs, here's the things in the next 4 years that we're really trying to influence or affect or change or prioritize. And it's relatively broad, but you'll see some specificity in there of things that we're trying to achieve. Beneath that would be your Department of Health division plans, where that's going to get more specific to the public health division, for example, or the behavioral health division. Then underneath that, nested within that, I would add your health stat performance management, where you now see even more granular program functions of where does that fit in the division strategic vision and in the department strategic vision. And we're certainly not perfect, Mr. Chairman. It's an iterative process, but something that we have definitely been prioritizing over the past several years. So I think the strategic plan is kind of that broad governing document that you're talking about.
Thank you. I have one other question, but before I do that, Representative Sherwood, Senator Larson, do you have any questions to throw in there?
Thank you, Mr. Chairman. I think going back to the mental health services, I don't know if I heard this correctly. Did you say we have seen an increase in providers or a decrease?
Mr. Chairman, broadly, Representative Sherwood, broadly in the market, both nationally and in the state, we've seen a pretty dramatic increase in the number of providers. If you think about it, over the past 10 to 20 years, private insurance has started covering more behavioral health as part of their benefit plans. Medicaid programs have opened up codes to pay for more behavioral health. So you see a provider influx because of that. But in state-funded community behavioral health, like the unit we're talking about here, we've actually seen a decrease in the overall number of providers, mostly through consolidations, buyouts, that type of thing, because the mission is very different, right? We're talking about state-funded services, and with the reform, really state safety net funded services for priority population. So a little bit of both.
Any follow-ups, other questions? Okay, I had one slightly different one, and perhaps this is more for Mr. McVicker, but in going through this, I noticed we're using some of the trust fund on tobacco, and it goes to a number of different programs in various amounts. Are there other trust funds like that benefit various agencies? And is there some sort of a report that shows these are the trust funds, these are where the monies go, and the status of those?
Yeah, Mr. Chairman, members of the committee, a new one that just came out in the last few years is our opioid settlement funds, which will look very similar to the tobacco funds that we give to our public health and also our behavioral health areas. Those are the two major ones that I'm aware of as far as the trust funds go. Both of those are handled and run out of the Attorney General's office. And they let us know when funding is available, and we will be levying those funds into our budget.
Okay, so I guess the question then would probably go to the Attorney General's office. Is there a balance sheet of effect so we can see where that money's going?
Mr. Chairman, yes, for sure there is. We work collaboratively with them. But yeah, for the details on the overall for the state tobacco fund settlement and opioid settlement, that would be an Attorney General. They would have that detail.
Thank you for that.
And Mr. Chairman, if I may mention, with the funds, the state settled with various opioid manufacturers, pharmaceutical companies in that opioid settlement fund. The state, part of that settlement was that the state gets 35% of the overall settlement, and the counties get 65%. So we actually, for what the Department of Health receives, as Eric mentioned, through our public health division and our behavioral health division, we have an annual report on our website that we're both required to produce and want to produce that shows between those two divisions, here's how much money we received. The most recent one was as of January of this year, so it's dated. It's an annual report, but it shows not only the funding that we've received, but the breakdown between each division of what the plan is to spend those funds, and another column that is how much of that in that plan area has been expended. So we're should you be interested, it's on our website, or we're happy to send it to the committee.
Thank you. Other questions? All right, Director, please proceed.
Thank you, Mr. Chairman. We'll move now to the Division of Healthcare Financing. A couple of things I wanted to point out here. This is obviously our largest division by funding in our Medicaid program, with all of our different both mandatory and optional programs like our waivers. So we could spend a lot of time here, but I selected just a few priority snapshots and performance reports. And I want to start in the first section of it, which is on page 65 of the Health Stat reports. And this is something that I know we have Jesse Springer online, who's our interim state Medicaid agent. He's been heavily involved in and really done some great work with the Division of Healthcare Financing and Medicaid when it comes to Health Stat, and thinking of what is not only the best way to communicate and visualize our Health Stat performance data, but the Division of Healthcare Financing also does their own internal micro Health Stat. So they do, in addition to Department of Health performance management through Health Stat, they do their own process at the division level, which has resulted in some of the things you see here. He made the recommendation years ago, which I think was a good one, to kind of have a Medicaid overall snapshot, because we have a lot of different functions and services that Medicaid provides, but from a decision maker and a policy standpoint, having the overall snapshot, what's Medicaid in one page, that's what you can see on page 65, which I think is very helpful. And again, you can see the program description, the total claims cost. So that's money that's going out the door paying claims from providers. And you can see about $673 million in fiscal year 2024, with an average monthly enrollment at that time of 76,000, just under 77,000. The cost per person, we can inundate you with detail should you want. We do per member per month reports. We do the Medicaid annual report. A lot more information behind the Health Stat document, as I mentioned before. But this gives you a sense of, you take all of those populations that we cover in Medicaid, both mandatory and optional, long-term care, nursing home, waivers, Medicaid state plan, children, and we roll that up into what's our average per member per month cost. And you can see that there in the most recent fiscal year at around $707. Program cost notes, you can see pretty easily. Generally speaking, we have a 50-50 split between state funds and federal funds in Medicaid, but you see some interesting detail there that there's also enhanced match rates for different types of things. For example, Kid Care CHIP has a 65% federal match. Technology, when you're implementing new technology systems, and that kind of work comes with a 90% match. Operation and maintenance of technology systems, 75% match. So a lot of ins and outs, a lot of what have yous in Medicaid, but you can also see on the right-hand side of that document our total program staffing at around 117 full-time employees, and then broken out by some different measures that you see there. If you flip to the next page, again, this is kind of macro for healthcare financing, not a specific program or coverage or population per se, but again, kind of resulting from Mr. Springer's good work over the years and the staff at Healthcare Financing. We have an overall goal of maintaining an adequate provider network, not only for our Medicaid beneficiaries or Medicaid members, but also for the state healthcare system writ large, of which we are a big payer in terms of overall healthcare at hospitals and clinics and nursing facilities and other places in Wyoming. So you'll see this is more of a performance report than a snapshot, looking at the core purpose being we want to ensure client access to an adequate and accessible healthcare provider network through the management of provider enrollment and reimbursement, really on the things that we control on the policy and management end. Provider enrollment, the types of fees or rates that we pay for service really does have an influence on the density of the provider network we see. So the outcome measures you see there listed are really around physicians, nursing facilities, hospitals, pharmacies, and dentists, and kind of the same aggregate measures for each one of them. What are the percent of in-state licensed providers, in this case, top one, physicians, that are eligible and enrolled in Medicaid? Same thing for nursing facilities. The percent of in-state licensed, eligible, and enrolled nursing facilities, so that we get a sense of what are we seeing that can help not only inform our policies on how we manage our providers, how we regulate our providers, how we pay our providers, but also for you as decision makers. And I'll get to a few examples here in a minute of this. These are some of the things that when we have our staff and our experts come to us and say, hey, we've seen a huge dip in the number of dentists that are enrolled in Medicaid, for example. What's driving that? Is it reimbursement rates that they're saying we're not going to serve those people, we're not going to take those rates? Is it payment policy, right? Are we not paying quick enough? Is it provider enrollment? Are we too stringent or not in terms of what we're requiring those providers to demonstrate, or how we're prior authorizing services? Things like that can be more regulatory really does help us as decision makers internally. But also, Mr. Chairman, you all as appropriators and legislators, these are the kinds of things that generate, the budget requests that you see, where we may determine that particular drop in performance of provider enrollment, for example, necessitates a rate increase or necessitates a policy change on our end. So again, want to be as transparent as possible that these are not just reports or data that we collect for ticking boxes and making sure that we keep our staff busy, but really to govern and direct, what changes do we need to make, and is that within our control or is that outside of our control? Okay. The next one, again, kind of an aggregate performance report, is on page 69, and that's Wyoming Medicaid financial monitoring. So this is something that, again, it's a performance report, but it is absolutely more in the aggregate sense. So we look at our overall per member per month cost because we want to keep tabs on that, because that can put budget pressure on the program, both in terms of internal policy decisions and state policymaker decisions that you all might face. And we break that out by our different types of categories. So overall cost on a monthly basis for children, for non-disabled adults, our family care adults, or our former foster care kids, for aged individuals in our community choices waiver, our nursing home. You'll see PACE on there, which was a program we used to operate, but as part of the 2021 budget cuts, we eliminated PACE as a program. Our disabled individuals, both through our developmental disabilities, comprehensive and support waiver, and also our supplemental security income, or SSI program. And then we also look at benchmarking. So we look at that same per member per month kind of measurement, and we say, okay, what do our kids look like in comparison to kind of a separate Medicaid program, but for higher income kids when it comes to the CHIP program, Children's Health Insurance? Do we see similarities or differences? Look at the child marketplace for private plans, the adult marketplace. And again, have to give a lot of credit to Jesse Springer here for developing this report to see not only what we're looking at internally in terms of Medicaid, but how do we compare? Noting that Medicaid in Wyoming, we cover long-term care, we cover optional services that most private health insurance plans don't. So we're going to see cost differences, but it's really good to benchmark that in terms of how does our performance compare to other large health plans, and what are things that we could be doing to mimic that or match that or improve our financial performance and overall cost for the taxpayer in Wyoming. Mr. Chairman, if I can, I'd like to stop there and both ask if there are any questions, but also, since I went over very quickly a few very high-level Medicaid reports, see if Mr. Springer had anything to add that would be helpful to you all.
Chairman
Sorry,
Pender.
I muted myself. I said absolutely good to see you again, Mr. Springer. Have at it.
Thank you for having me. So we do take Health Step very seriously, Chairman Pendergraph. So we use it extensively in our operations. And then we do have deeper reports. So this financial monitoring, for instance, we have a full per member per month report, which is also on the Department of Health website. We have an annual report, which kind of backs up the summary, which, depending which questions we get, we try to answer those kind of in advance. In our annual reports and our PMPM report, we also have some county report type concepts that are dashboards that we've built. So when we get requests from the legislature, our hope is that between these different reports that we built and the health stat, we already have a lot of the answers available, and we can get an answer either immediately or within a day or so. So that, there's not this really long time span between getting a request for information and us being able to respond. That's really it. I think Director Johansson knows Medicaid so well that he covered it better than I could have.
All right. I had a smart aleck comment there, but I'll hold it to myself. I'm trying to learn to be a little bit more professional.
Mr. Chairman, I can almost assume exactly what that comment was, and I could have made it myself. But moving on, I'll be very brief with the rest of Medicaid, just a few more examples. I want you to turn to page 72 and 73. Again, all credit to the staff at Healthcare Financing and Mr. Springer here, looking at overall macro health outcomes within Medicaid. It would be really easy for us to operate a very complicated, very costly program with all the ins and outs and the regs and the budgeting and the systems and all of that, and say that's enough to manage. But we really want to see through health stat how are we doing on these things that we can measure in terms of health outcomes, event rates, things like that, and point you to a few outcomes in terms of looking at are we getting better or worse on what we call early and periodic screening, diagnostic and treatment, or EPSDT, which is really directed at children. And we want to see those trends at the state level go up. And you can see that that we're not always in line with the national average. And it's something that we take very seriously in terms of performance. Looking at emergency department visits, that's your next outcome there. We can see we want that trend to go down. And I'll get to some of the bigger outputs here in a second. Follow-up after hospitalization for mental illness. We want to see that follow-up go up. We want to see the same thing go up for your adult population there. Rate of diabetes inpatient admissions to a hospital per 100,000 member months. We want to see those diabetes-related inpatient admissions go down, and we want to meet or exceed the national average. And then you see a very specific, has grown over the years in terms of interest, the number of high dosage opioids per 1,000. Again, we want to see those trends go down. It gives us a sense, again, at a macro level. This is before you get into all the various programming and coverages that we have. These higher level outcomes that I think Jesse would reiterate this, that we want our programs and our functions oriented towards those macro outcome measures. The services that we're providing should be avoiding not only these costly stays at hospitals or ER visits, but also for people's lives. Those event rates can indicate maybe we're not doing the right things. Maybe we're not paying for the right things. That directs us towards our reimbursement policies or our regulatory policies on how much we're allowing to be provided, or if we're allowing too much. Again, gives you a general sense that you can see mirrored on the next page 73, with just the output. Look at the raw measurement of emergency room visits per 1,000 member months. Looks like a really good trend here, and I hope that it is, where through the population health programs that Medicaid has and targeting certain types of clients, trying to coordinate care better, we want those emergency visits to go down. You see that broken out on the previous page more granularly, by population. But the thing I'm maybe most proud of with Jesse and his team is that they're very humble And we just had I'll get to this in a minute, but we had a performance management meeting, health stat meeting last week with our community choices waiver administrator. And I was seeing some very positive trends on those long-term care members who are being served in their home and communities, where the number of ER visits and inpatient admissions was trending down significantly. And I was ready as director to praise the staff, and I did, but was met with a response that's, wait a second. Number one, there's probably some trends from the pandemic where folks were going without care that are influencing those numbers. And secondly, we got to be concerned. We can't give ourselves total credit, because what if some of our members are not seeking appropriate care in those settings? And again, it's just one example of kind of the complexity of a decision maker like myself can say, hey, great, emergency room visits going down. That's really good for the budget. That's really good for our overall health outcomes, something we can report to the legislature. But there's caveats within caveats on that. We always are trying to deep dive to find the root cause of those issues, whether the outcome measure is going up or whether it's going down. So again, Mr. Chairman, gives you a sense of the kind of day-to-day, week-to-week, month-to-month discussions we have internally about how we're doing.
Thank you.
I'll move you now, because I just mentioned it, to page 87, which is our Medicaid long-term care summary. That shows you the example that I was just talking about. If you look at our outcomes report there of the rate of ER visits per 1,000 member months, and CCW means community choices waiver. That's essentially our home and community-based option for folks that could otherwise be served in a nursing home, something that we've talked about with this committee quite a bit. We've talked about with the Appropriations and Labor Health Committee quite a bit. And again, you can see that overall number trending down from 136 in fiscal year 19 to under 60 in fiscal year 24. Again, that's really good as a raw measurement to say we're reducing ER visits, but always, as our experts and Jesse's staff will tell you, we got to make sure that there's not unintended consequences of that, where folks have appropriate access to care, whether that's emergency care, hospital care, et cetera. But by and large, in raw numbers, again, good for the budget, good for the general outcome measurement for the Department of Health. But again, Mr. Chairman, just an example of a Medicaid performance report that just has a lot of detail behind it. I'll stop there, see if there's any questions.
Any questions, committee? I think we're free to proceed.
Okay, last example, we'll move to the Public Health Division on page 184. I just selected kind of randomly, there was no rhyme or reason for this. I selected our Wyoming Cancer Program in public health. And so again, very different division than Medicaid. Public health, very different, as is behavioral health, as is aging. But what I want to reinforce here is almost the same look and feel with performance management. Give us your snapshot, program description, the cost, the number of people served, some cost notes, funding breakdown, and then give us a performance report that shows the same value chain as we see in every other Department of Health program. So in this program, mostly supported by federal funds, we have about a $2.5 million annual program expenditure with about 2,600 or 2,700 people served. This is for things like breast and cervical cancer screenings, colorectal cancer screenings, and referral to treatment if cancer is detected. So this is a program where for certain parts of the population, primarily low income, we offer free cancer screenings to try to catch those cancers, specific cancers, earlier. And we know from the research, from the literature, from the data, especially with colorectal cancer as an example, the earlier you catch that, the more likely it is you can resolve that issue through treatment. We also know through the data that colorectal cancer in the general population has been growing over the years, and especially growing among younger and younger individuals, which I'll get to here in a second. But this gives you a sense of what the program is, how much it costs, how many people we serve. And I want to point you to the last line on the snapshot in the program expenditures and people served, that our non-600 series expenditure, kind of contrary to some of the examples I gave earlier, is much higher. This is more administratively heavy because if you think of the screening kits that we provide or allow people to receive, colorectal cancer screening, et cetera, there's just more administration and more non-direct client benefits in terms of an actual service that constitute this program. But as always, you can see, there's caveats among caveats in all of this. So in all of these snapshots and performance reports, you'll see little asterisks and little footnotes that hopefully give you a sense of, helpful information to know when you see a macro measurement, there's always a lot of information behind it. And that leads me to page 185, which I won't linger on, but I just wanted to mention it to the subcommittee that in all of our snapshots, we allow our programs to give us some narrative on recent events that have shaped the program. And that can be things like recent statute changes that the legislature made, bills that passed that influence that program, federal changes to grants or funding sources, staffing changes, like we had 60% turnover in a particular program, and that really impacted our operations. Whatever the case may be, we give some, as much as us data people hate this, we give some room to provide some narrative on recent events that have impacted program performance or program operations. But I'll move your attention to page 186, where you can see the outcome measures for this program. The first one, percent of those enrolled who were screened for breast and cervical cancer. So we provide both a numerator and denominator, the percent over the total. We have a target of 80%. We are beneath that. And we've had our cancer program manager in, not this most recent year of HealthStat, but the previous 2 years, talking about what's driving that. Why are we not hitting that target? We want these people who are enrolled to take us up on this service to screen out these different types of cancer. And there's, various elements that we've changed, a few of which I'll get to. But your second outcome measure is the percent of those are enrolled who were screened for colorectal cancer. So same measurement. We want to hit a 60% target there, and we're well beneath that. You can see we're most recent fiscal year, we're at 25%. I will note the caveat there that you can see below that table that a lot of these programs, really regardless of where you are in the department, you'll often have data lag. So the most recent, fiscal year's full data might not be available in some of these measures. We do our best to note that, but I would encourage the committee, the subcommittee, and anybody reading the HealthStat documents to always take an impressionistic look at several years of data, right? So you can really see a trend. And if you see a massive drop off, that could indicate a massive performance issue. That could also indicate that at the time of publication, that fiscal year's data was not yet complete. And we do our best to note that. But I want to linger on this colorectal screening measurement because you can still see, even if that was a data issue, we've gone from 50% in fiscal year 20. Even if you just go to fiscal year 23, it's down to under 30%. And our program manager, our expert in this area, came to us in HealthStat at the time, scheduled for the performance, and said, we got a problem. This is going to result in cancer being identified too late, which increases cost in the healthcare system, could potentially cost lives, et cetera. And we were asking, what's going on? And there's a lot of things going on there. There's a lot of things we could do as developing solutions, et cetera. But she came to us and said, the national best practice is to recommend colorectal screenings at age 45. Our statute in Wyoming that governs this program I believe it was at 50 or 55 years. And so we could not, even if we wanted to, say, let's offer these screenings. It doesn't have to be a cost change, a budget request, anything like that. But let's offer these screenings to a younger population. So after the HealthStat presentation, which before the HealthStat presentation, a lot of work in the public health division to dig into the details, see where the levers that we could pull were. We took that information from HealthStat at the leadership level, came to the legislature several years ago. You guys ran a very simple bill through the Labor Health Committee. There's no money attached to it. Let's take that number down to 45. And the bill passed. The governor did a formal signing. We had our program manager there saying this is really good news. And so now we're in the process of what I hope you see in fiscal year 25 is that percentage increasing because we've made that eligibility lower with no need for additional funding, but hopefully catching that colorectal cancer earlier. And honestly, something that we can't deliver to you because it's very hard to measure it longitudinally, but we would love to. We hope that we're saving lives by doing that. And again, using mostly other funding sources, federal funding sources, et cetera, to deliver what is, not an often talked about function of the Department of Health. It's not the biggest, it's not the highest staffed, it's not the highest cost, but one that really does have that true kind of preventive benefit of identifying something that can really lead to a death or lead to immense cost and struggle in the healthcare system. So, Mr. Chairman, I'll stop there, see if there's any questions, but really appreciate the time to go over HealthStat. It's been a more than a decade endeavor for us, something I'm really passionate about and something I'm really proud of the department for trying to develop this culture of performance and be honest and humble about the results we're getting and celebrate those, but also the results that we're not and try to diagnose and analyze why we're not performing well and bring those issues to decision makers.
Questions, committee? You just want to go to lunch, don't you? So, if I may ask, under public health, we have a 100% federally funded disaster preparedness, the healthcare preparedness program. And a little farther down, we have public health preparedness and response, also 100% federally funded. Why are these not, from the outside looking in, why are these not just one department?
Mr. Chairman, it's a good question. They are managed within one unit, and for the purposes of HealthStat, because of the different paths they take in what type of preparedness or who, we've carved them up as two separate programs. But in terms of the department's organization, this is one unit in the Department of Health called Health Readiness and Response. But we don't have, and it's an interesting point. We've gone over this and debated it for years. Should we have division level health stats or unit level health stats? We've kept it for the past 10 years or so at the program level, broadly speaking, with the exception of some of the Medicaid reports that we just went over that are much more macro. But that's the simple answer to your question is those are one unit, one function in the department, but we've broken them out as two separate programs just because of the differences in how those federal funds and essentially what type of preparedness activities are happening, but certainly managed under one office.
Okay, so it's not necessarily then a question of could there be better efficiencies by combining these? They already are. They're just reported separately.
Mr. Chairman, in general, yes, but forgive me because I know this to the public probably is like watching paint dry, but this stuff excites me. We're always asking those questions, and so even within smaller units, we're looking at span of control, the number of staff, the number of contract, AWAC employees that we have. Can we do more with less, or can we not achieve those program functions without additional staff? Those I can't answer your question directly because, frankly, off the top of my head, I don't know if there are more efficiencies we could suck out of a unit like this. But to your point about seeing 100% federally funded, it's one of those issues that in previous budget cut cycles, like we talked about at our last meeting, many times you all as decision makers would say, well, yeah, we could realize some efficiencies there by turning off a function or reducing staff, but the state general fund won't benefit at all there, right? And so in some previous budget cut rounds, those have been deprioritized to say, well, we're really only concerned about state general funds, and that won't help us at all. But as a director, as a manager, I'm constantly looking at that to identify, well, that's still staff time that could be repurposed elsewhere. And maybe that can't work under the current funding structure with those particular federal funds. But is that something that we could repurpose for another benefit of the department or another program or another function within public health? My senior administrators would tell you that, that's a question that's constantly asked, especially as we're preparing to set a biennial budget.
Well, regardless of where the funds come from, it's always good, to have that efficiency mindset and how can we do this better?
Mr. Chairman, the last thing I wanted to mention, and again, happy to answer any other questions, but if you'll permit me, just a few things. I did want to mention on page 235, this is something we added several years ago. It is really only directed at you guys on the Appropriations Committee because frankly, nobody else cares. This is the technicality of Department of Health funding, but we provided a map with all those programs to all of the budget strings that they have. So on the very technical side, you guys ask these questions a lot during our hearings or when you're trying to set the budget. And you see those, budget string and revenue codes all through our budget book. So in an effort, even though it doesn't port over the whole health stat binder, doesn't mimic the budget book entirely, we tried to put a reference document in here to say, hey, in that legal services and legal developer program, you're going to want to look at 5002. I mean, that's the general budget string that we have there. So those are the budget units that you can see throughout the department, and hopefully it's helpful to tie. Okay, if you were going to look at that program and see where it shows up in the budget, you can see those codes, those budget unit codes or budget strings in there. Again, not a perfect solution, but something that in previous discussions with the Appropriations Committee and the governor that we thought on the technical side would be helpful. Should you be dealing with a big decision about a funding request or in some cases about a budget cut, to be able then to go cross-reference the budget and say, okay, what all is in this budget unit in addition to this program, and what are some of those connections or unintended consequences or what have you. Lastly, Mr. Chairman, just wanted to close with some of the challenges. As proud as I am of HealthStat and the Department of Health, and something that we have really tried to build up, both in terms of the reports that you see, the data acumen across our staff, but also in terms of that culture of performance where I want our program managers and our folks to come to us and tell us where things are not working, and that took some time to develop that comfort and that humility to say, hey, I don't think my job's on the line if I tell you we're really terrible at this outcome measure. And I'm confident I can tell you that we are in that sort of moment in the health department for the past couple of years, where I've been very proud of the staff that have come to their presentations less fearful of this is going to be a disciplinary or personnel issue or my program's going to be cut, but in an honest way saying, if we want this program to succeed, we've got to take a look at where we're failing and identify what the root cause of that is. The other challenges with HealthStat, because I know I've promoted it a lot here because I am very proud of it, but we don't have anybody in the Department of Health whose sole job it is to do HealthStat. So this is all other duties as assigned. And I think that is absolutely appropriate. This is just a way that we do business. This is not something we need an army of 10 or 20 data analysts to be doing HealthStat. Could it be helpful? Absolutely. But we also want this to be embedded into the way not only our program managers think about their performance, but for them to know that that's how their leadership is thinking about their performance. But it's worth mentioning that both the folks who organize our HealthStat process, our every other Thursday meetings, the reports that you see every year here, the logistics behind it, all of the meetings, et cetera. These are all, things that we've assigned to staff to incorporate into their day-to-day with their other jobs. Secondly, Mr. Chairman, I'd mention, because it's something I have to mention, I would caution everybody reading the HealthStat documents and you all as decision makers as well, to make sure that there's an understanding. There's a lot of exogenous variables that influence the outcome measurements that you see there. It's very rarely a one-to-one where you say, we did this thing and we saw this outcome. And I'll use a broad example of a discussion we had in our last meeting about prevention. I believe it was in our Casper meeting, where it's very difficult to say we did this program activity or a local community did this prevention activity, and we saw this rate of substance use or this rate of alcohol use or our suicide rate drop. But I can tell you, and I'll use suicide and tobacco use as two examples. Have we seen a flattening of our, or a potential flattening of our suicide rate in recent years? Yes. And my staff would probably get upset with me for not saying, well, that's the result of all of the good suicide prevention work that's happening. But I absolutely believe that that's true. It's just very difficult to quantify. But the work that's going on locally, the focus that's being put on the issue, both at the local level with our prevention coalitions, with our Department of Health staff, with our governor and his office, likely correlated. It's just difficult to say it's causal. And we see that in a lot of areas of the department. So when you see some of these outcome measures, just give you a sense of some of the difficulty we have where, we might want to give ourselves credit, but some of the examples I mentioned before just prevent us from doing that. And we really want to have this culture of objectivity in addition to performance to say, was that really resulting from this program activity that we delivered? And, our home health services and Medicaid, our community choices waiver, do we think it's likely that we're offsetting or preventing nursing home costs and nursing home placement? Yes. But can we say definitively that every single one of those cases and clients would have been served in a nursing home and therefore we saved X dollars? No, we want to be honest about that it's hard to control for those things. So causality versus correlation is one of the fundamental issues philosophically and challenges we deal with in health stat. But again, I think it's a worthwhile endeavor. Hopefully this document provides you guys some reference materials to look deeper into our program performance. And going forward with this subcommittee, Mr. Chairman, or joint appropriations or the legislature in general, we're always open to feedback. You've brought up a few issues today that we'll absolutely incorporate into our planning for the next iteration, next year's health stat. But as we go forward, happy to answer any more questions that you have or provide any more detail you might want.
Thank you. I got a couple of comments, and first comment on the last thing that you mentioned, this causal relationship. We'll be having some discussions about that, very frank discussions about, what's the return on investment, and they are hard to measure. And I would cite as an example for the public, alcohol use, specifically beer consumption, over the last several years has gone down quite a bit. We've seen microbreweries collapsing and all that sort of thing. But we haven't seen a whole bunch of advertising on behalf of the federal or the state about how bad alcohol is for you. So something is happening culturally, which is affecting those things. And that's really hard to measure. And as you said, it'd be nice to be able to say, yeah, it was our ad campaign against opioids that really made all that difference. Well, maybe it was, maybe it wasn't. And that comes into discussion. Representative Sherwood, did you want to chime in on that?
Thank you, Mr. Chairman. I guess, yeah, being in college town, I do hear from our young people that they are less inclined to be out boozing. And we do see an increase in the NA, non-alcoholic movement. Again, where do you tie that to? But it is very much a trend that we're experiencing here in Laramie.
Thank you for backing that up from down there. Sheridan's a college town too, but not to that extent. So I also want to thank you, Director, for pointing out page 235. That effectively is I had missed that probably because it's an appendix and I don't think about gut. But that is precisely what I was looking for early on when I asked about putting line numbers in there. So thank you for pointing that out, and I'm sorry that I missed it on my own. I had a couple of other things that I wanted to bring up, basically because I've had a lot of public comment on them and allow you to respond. One of them has to do with your relationship with the CDC. And, change of administration has changed the direction of the CDC. Specifically, COVID immunizations, those sorts of things are kind of a hot button right now. And I've had a lot of people contact me and say, how come if the CDC has backed off and is no longer pushing the mRNA type vaccinations? In fact, in Canada, I think the indigenous peoples up there have actually declared it a weapon of mass destruction. And so there's been this step back, and I have these articles if anybody cares to see them. But the question and what was being brought up to me is, why is the state advertising we need children to be vaccinated against COVID when the CDC itself is basically freezing that? Would you be able to respond to that?
Mr. Chairman, happy to in general, and if there's any follow-up that I can provide the subcommittee with, input from our state health officer and public health folks, happy to do that after the fact. In general, we over the years have followed CDC guidance, and we're doing the same now. So the recent changes that came from both the CDC and the FDA, especially involving COVID vaccines, there was a lot of discussion, especially over the summer. And the committee called ACIP that makes those immunization recommendations absolutely did turn over. A lot of new appointees with the new administration on there, and we're considering very different guidance for the COVID vaccine. My understanding, and I believe we're in line with this, is what they have recommended for population 6 months old and up, is that the vaccine is approved and authorized, but with what's called shared decision making. And it's something that I want to, given your question, want to highlight to the committee, that we have always tried to balance our recommendations with encouraging people and directing people to have those discussions directly with their healthcare provider. We don't want to get into situations where we are, unless absolutely necessary, getting in between the relationship with an individual and their healthcare provider. That shared decision-making framework was kind of the big change from the CDC and ACIP recently when it comes to the COVID vaccine, but it has certainly continued to be authorized. We still believe that within that decision-making structure, that folks should make those decisions in conjunction with their healthcare provider for what's best for them. Second thing I'll mention, Mr. Chairman, is we do not require immunizations at the state level from our public health division or our state health officer for any adults. There is a list that's on our website that's been around for decades of vaccines that are required for school attendance and for childcare attendance for children. But COVID-19 vaccine has never been a part of that. But for our adults, again, these are not vaccines that the Department of Health, our public health division, require. And it's something that we always encourage shared, that kind of shared decision making with healthcare providers. Elephant in the room, Mr. Chairman, is that there has been a lot of drama and debate in recent years about the COVID-19 vaccine. And as someone who was trained more in economics than in healthcare, more than happy to gather my public health professionals and docs to come speak with the committee or anybody else. But I will mention that and reiterate that we've tried to make it a general policy that we believe that folks should make those decisions along with their healthcare providers, and I think you see that reflected in our policies.
I appreciate those comments. I might say that we live in a different culture today than we did, say, 40, 50 years ago. 40, 50 years ago, we didn't have the internet. We didn't have all these sources of quote unquote information at our disposal. And we did more rely on perhaps government entities to get us information. But as we move into the information age and people have access to all kinds of sources from other places, that's something we have to factor into how we operate. So I will leave it at that for now. I have one more brief question, I hope, and then we'll open it up for public comment, should there be any. Under the pharmacy program, there is a 50% federal match unless it's tribal, and that's 100%. Could you enlighten us a little bit about how that works and what the rationale is?
Mr. Chairman, I'll answer briefly. If Mr. Springer is still on, he can add some color commentary or correct anything I misstate. So tribal healthcare that's really through a treaty with the United States government and the tribes that 100% of healthcare costs are reimbursed by the federal government. So it's one of those kind of distinguishing populations in Medicaid where, generally speaking, as we've mentioned before, we have a 50% state cost, 50% federal cost. In the case of tribal members and what we call Indian Health Services, or IHS, especially for those services that are delivered in tribal facilities or on the reservation, that's something that the federal government reimburses us 100% of those costs. And that's true in pharmacy as well. Very general description there. If Mr. Springer's on, certainly I would invite him to make any comments there, Mr. Chairman.
Mr. Springer, if you'd care to expand.
Mr. Chairman, the key thing is it's the nature of the provider. So these are actually pharmacies that are run by Wyoming's two federally recognized tribes under an agreement with Indian Health Service. So about a year ago now, it's maybe a little bit less than that, both tribes have taken over full operation of all their healthcare system on the reservation. So previously those were like a federal agency called Indian Health Services was actually operating a number of those facilities, but at this point, both tribes are operating themselves through an agreement with the federal government. So when those providers provide service to a member of a federally recognized tribe, then that expense qualifies for 100% federal match. So that applies to medical services. So there is a unit in the budget that is called Indian Health Services. It applies to pharmacy. There is a nursing home that's operated by the tribes called Morningstar. They also operate an end-stage renal disease clinic. And all the individuals that go there that are enrolled tribal members, they qualify for 100% federal match. So if those facilities, which is a little bit rare, depending on the facility, serve non-Native Americans, they don't actually get 100% match. So it's not very common, but some individuals in those communities, for instance, use the end-stage renal disease clinic. It's the closest one by 100 miles for them, so they use that clinic. There are a few people at the nursing home that are not Native Americans, so we don't claim 100% match for them. So similar on the pharmacy, it's not super common. Usually it's about 5% or less of the individuals are not Native Americans. But
thank you for that. And I'm just gonna. When I saw that, part of my feeling, and we spoke about it earlier when we talked about 100% federally funded, so it kind of drops it as a priority, for the state to look at. My fear is that you guys can't do anything about it, but that 100%, especially in light of opioid use, it just seems like it would kind of incentivize. Isn't it easier just to get a prescription and not pay for it anyway, and kind of mask over things rather than get to the bottom? So I don't expect you guys to respond to that, but these are the type of things, as I read through this, that I began to think about what are we doing, and is it what I think is best for people? And that's probably more.
If you don't mind me responding, though,
No, please do.
we still have utilization controls on services, regardless of the federal match level. So our pharmacy team, which we have a great pharmacy manager, Corey Cooper, they set up proper prescribing limits. There's safety limits that they review. Once it goes over a certain level, it can trigger prior authorization to make sure there's a condition like cancer or a burn victim to make sure that level of prescribing is appropriate. There's follow-up, there's step-down therapy. There's all sorts of things that are occurring, and those aren't really tailored in our world. We don't, the people that are doing that don't know the federal match rate of the person that's getting those services. The utilization management is not driven based on our federal match rate. So we're doing those same activities, whether somebody's 100% federal, 50% federal. It's really just medical appropriateness and safety. So we're following up on those, and that staff has worked through time to lower those prescribing standards through the opioid crisis and make sure that's happening safely. On our health stat, there was a noted where we saw some issue. We actually worked with the federal government, worked with the pharmacy team, and we're actually redoing how we measure those, mainly because we weren't properly excluding everybody that the federal measure did. So, that's when we saw, hey, we're not doing the best on this measure. Why are we really standing out here? And we went through and said, is there anything we need to change policy-wise? Is there anything we need to work on to make this work better? But also, are we measuring this correctly? I mean, the first thing I jump to when we're the worst or the best on something is, are we measuring it correctly?
Yeah.
And then once we make sure we're measuring it correctly, we work through what other changes we can make.
Thank you, Mr. Springer. Any other questions or comments from the committee? Okay, seeing none, is there any public comment? Representative Stivar, anyone else? Seeing none, I sense that it must be time for lunch, and so we will break for lunch. We'll come back at 1 o'clock and resume with the agenda at that point.